So a very good afternoon to one and all. It's indeed a privilege and honor to be here for this 12th World Dental Science and Oral Health Conference. Firstly, I would like to congratulate all the fellows and thank you. I would like to thank Dr. Anmol Bagaria and her team for organizing this wonderful conference. Now, I won't take much of the time, but I'll be taking you through a different journey. I'm not a clinician, but a forensic dentist. You might be taught about forensic dentistry in your UG or maybe in PG. So I'll be taking you through a journey in forensics. So I come from the land of Gujarat. Greetings from the National Forensic Science University. We come directly under the Ministry of Home Affairs, Central part. This is the laboratory where I practice. We do a lot of academic work, we do a lot of training. Specifically, we are into the caseworks. So when we talk about forensic dentistry, it's nothing new in the concept, but it's the branch of that dentistry that leads to the investigation. We are actually helping the law enforcement agencies. We work with the judicial officers, we work with police, and we try to investigate the case. Now, as a dentist, right from our first year of BDS, we are taught about basics of dentistry, basics of dental anatomy, and yes, teeth is very unique in nature in terms of its robust appearance. We have done a lot of work in understanding its uniqueness. Teeth as such is very resistant in nature. It is resistant when we talk about mechanically, chemically, biologically. These are the photographs what we have taken after the due experimental work what we have done. We have exposed it to different types of acidic environment as well as the fire cases. So right from our anatomy to histology, also incorporating the radiology, dentists play a major important role in investigation through dentistry. Now the first mode of investigation, whenever a law enforcement officer or the investigating officer goes to the scene of incident, this is the first mode of identification what he does. He just looks here and there and tries for visual identification. And we are fortunate enough to see different types of human remains when we talk about Mars disaster, Mangalore plane air crash, WTC World Trade Attack Center, and Uttarakhand flood. Right from mutilated bodies to skeletonized bodies, craniofacial structure play an important role. And yes, the first thing what we do is documentation. Documentation through photography, documentation through sketching, documentation through writing notes. After due documentation, we do the detailed biological profiling based upon the requisition received from the IOs. So either it is determining the sex or understanding the age of the person, ancestry, stature, DNA, so on. Now, as I said, the investigating officer is the first one who goes to the scene of incident and goes for visual identification. But we are fortunate as a dentist community, or else I would say the dental community, because the highest body in the law enforcement agency, that is Interpol, has identified the role of dentists in investigation. So that is the reason dental structures are considered as primary identifiers. I was one of the Indian representative to participate for the DVI workshop or DVI conference at Singapore in the Interpol, and where they have clearly narrated that fingerprints, DNA and dental plays a major important role. So we have we have utilized dental structures right from our first year of UG. But today I'll be taking you through a different journey that is called digital forensic dentistry. When we talk about basic research practices as a UG student or a PG student, this is what we do. We try to understand the dental structure, read certain papers and derive our I would say, get our equations done. But when we talk about advanced research practices, when from the forensic perspective, we are understanding the facial recognition part, the facial morphology, the taphonomical part. These days, everyone wants to upgrade themselves in every sector. When we talk about oral medicine, radiology, oral pathology, we are talking about next level of dentistry. We are talking about robotic surgeries in our medicine practices. We are talking about the 3D prosthetics in our or the orthetics. We are talking about the artificial intelligence in the radiology department. And so we do also promote digital dentistry in forensics through new practices, that is incorporating 3D technology, or when we talk about machine learning, artificial intelligence. Now, why do we need digital concepts in forensics? We should be happy with our conventional technology. No. These days, even the law enforcement agency wants quick, rapid results. Because yes, as one Dr. Garima mentioned about, she was scared when she had to do the treatment of a lawyer. And this is what we normally do. We go to the courts and we have to submit our reports to the judicial officers. So it should be quick in nature, better in accuracy, ease of sharing. When we talk about better in quality, they are related to scientific evaluation. When we talk about world as such, be it in UK, US, Australia, any kind of well-developed countries or even developing countries, when I participated as an Indian representative to the Interpol meeting, we had a delegation from Nepal, we had a delegation from Sri Lanka, we had a delegation from Bangladesh who talked about the digitization aspect of forensic odontology. And yes, I was being invited to participate at the Visual Technology Research Group. It is one of the forensic network of UK, and we discussed about our practices, what we do in our country, in our university. So when we talk about forensic dentistry or digital forensic dentistry, the first mode of, I would say, the methodology is comparative dental identification. You are comparing something. You are comparing with the antemortem records. But yes, we do have some challenges. At times we don't maintain our dental records. We make a lot of fake records, right? So at that time we go for reconstructive identification when we don't have records, when we don't have a solid scientific records. We are in a position to estimate the age, gender, race and other traits through dental structures. Forensic dental assessment is one of a major tool in India. What we do a lot of cases for Sports Authority of India, for different bodies in understanding the age. And age is an important parameter for civil criminal cases. And as a dentist, we have always done a clinical assessment, when specifically in the pedo department. So clinically, we have understood the age, radiologically, histologically we have done. And when we talk about the advanced practices, when we talk about the new technologies we use, OPGs, we use CBCTs, we are using the CT scanning technology to understand the age through different radiological techniques. The second parameter for investigation or for identification is determining the sex of an individual, which is an important parameter. The reason is, when we give a statement to the police officer that, Sahab, the dental remains or the remains belongs to male, their 50% of their work is reduced. Instead of searching both the male and female records, they are now just searching the male records. So we are actually helping the agencies. So yes, we know right from our first year, we are taught about the anatomy, the dental anatomy, and yes, we are in a position to identify accurately up to 75% with the help of the teeth itself. And when we talk about the craniofacial structure, the bones, it's 95%. We do a lot of studies in terms of not only morphologically, we understand radiologically from the ortho perspective also. We have digitized the specimen in understanding through the CT analysis or through the radiological analysis when comparing it to the morphological. As I said, today I'll be talking you from a different perspective, not from a clinical perspective. Now this is one of the major area for forensic dentistry, I would say. This is very fascinating to the press media. It clearly catches it comes in the newspaper that yes, there is a bite mark normally involved in sexual assault cases. Bite marks are found in even domestic violence cases. We see different kinds of bite marks. We have seen not only human bite marks, we also analyze animal bite marks. So bite marks are common in these cases, and as a dentist, when we venture into this area, we are actually helping the judiciary system and the society. There's one such case wherein this was a female lady from outside. She came to Goa for just for vacation, and that's how there were men who attacked that lady and severe bite marks on her body. Through basic digital documentation, photography, we were able to close the case. As I said, it's just not about photography, it's also about radiography. We use our oral medicine principles, that is CBCT, and we are able to do a comparative analysis understanding which animal has bitten. Now, because that's also a crime. Yes, we do a lot of non-invasive technology work in terms of rugoscopy, or I would say the chelioscopy, the lip print analysis, to understand, appreciate the patterns. As I said, advanced imaging is one such area where we work through CBCT, CT analysis, because forensic evidences and human cadavers can be scanned at any period of time. We don't have to open up. And secondly, we can visualize the structures both from outside as well as from the inside. So that is one such methodology where we use CT scanning technology. This we use a surface scanning technology for digitizing the human remains, which is brought to the department. With the help of radiologists, we do a lot of image segmentation because we have a new concept called virtual autopsy. Without cutting open the body, we are in a position to understand the cause and the manner of the death. So where again a forensic dentist can be involved in the entire team. So we do a lot of segmentation of the structures and to appreciate it visually. After 3D scanning, we have ventured into the 3D printing, a digital area. We have printed a single tooth in different manner using different technologies. So that's one specific case for which we had utilized CT scanning technology. We have printed it and then utilized for the biological profiling. As you understand, for forensic cases are very crucial in nature. We can't play with that structure. So we create a lot of copies to understand, to analyze. We have prepared different model for visualization, both from 3D imaging perspective and 3D printing perspective, from the skull, from the face, from the palm. And later we utilize it for the analysis, doing a lot of digital analysis in terms of linear measurement, circumferential measurement, surface contour, and so on. Now, one of the major challenges in forensics is we get lot of fragmented cases, specifically when we talk about disasters, when we talk about when the evidence are being smashed so that the identity is not being revealed. So the conventionally what the forensic scientists or the forensic medical experts they used to do, they used to use cyanoacrylates or adhesives to join the specimen, which at times creates a problem for biological analysis when we talk about DNA. So we came up with a concept called reconstructive forensics, and we digitize each and every small fragments and utilize the method what we have been learned in CAD/CAM technology or through prosthodontics. We utilize the 3D technologies to reconstruct the specimen. So we have reconstructed the broken tooth, the mandible, the skeletal structures, and later we utilize all these structures for the forensic profiling part. And yes, we have received, as an academician, we make sure that whatever we are submitting to the court, it's valid scientifically. So we do a lot of experimental work first and then publish the data. Now again, when we talk about forensic superimposition, now this skull is my own replica. I got myself CT scanned and then prepared the 3D printed replica, just to understand whether the forensic superimposition can be utilized or not in forensic investigation. Because for the very first time in UK in 1954, the forensic superimposition was taken up. And very recently, when we talk about in Maharashtra, the Shinabura case, there again the forensic superimposition was taken up, but the judiciary officers had challenged the technique. When we talk about the next technique, apart from forensic superimposition, we do a lot of forensic reconstruction work. I would say we get a case every month to 3 months. Recently, we have completed a case from Delhi Police and one from Gujarat Police. I'll be showcasing that specific case. So again, I would like to say that whatever we are giving to the judicial officers or to the legal fraternity, it has to be very, very scientific in nature. Otherwise, we are again questioned. Now, when we talk about the digitization of forensic practices, now we were the first one not only to venture into 3D forensics, but we have developed a specific app mainly on virtual reality. Now, as young minds, we like new inventions, new innovative works. So we came up with a new tool that's that's a forensic software. Mainly, we have designed for the police officers so that they can get themselves trained in forensic dentistry with the basic understanding of human bones and the body. So they don't have to visit the crime scene or the scene of incident on a regular basis. That's how we can preserve the scene, and we can promote the teaching and training in best possible manner. So one such case I would talk. The first case which was referred to us for reconstructive forensic was long back in 2018, where a police officer had brutally killed his own wife. And because there were a lot of skeletal and dental sample, got a call from the Joint Director State Forensic Science Lab that, "Doctor, there is some skeletal remains as well as dental remains. Can you help?" I said, "Yes, let me come to the scene of incident." We did certain morphological examination, we did the radiological examination, and there for the very first time we digitized every specimen, created, reconstructed the tooth and did the profiling. And we were in a position to identify the gender, or I would say the sex of the specimen, a major breakthrough in that specific case. Second such case, which was referred to us from Maharashtra, a decomposed body, and there they wanted to identify who the person is. So as I said, when we talk about forensic odontologists, we are in a better position to say who the person is, Mr. XYZ. So we did the proper maceration of the specimen, we did the digitization of the specimen both in the imaging format as well as the printing format, and then we did the 3D facial superimposition, and we were in a position to identify who the person is, and through a positive identification. So that's how one more case was closed. This case was referred to us from the eastern part of India, that's Tripura, where from the scene of incident they recovered a denture. Now again, when we talk about the denture, we always think from a clinical perspective, but when it was given to us for investigation, we had to inform who kiska denture hai, whether the person is male or female, what would be the tentative age. Based upon our knowledge and expertise from the prosto part, we first digitized the specimen, and then we were able to provide the report to the director. We were in a position to identify, yes, the denture belonged to male based upon these criteria. This was a very recent case referred from the investigation agency, as you know, the Intelligence Bureau. So they were suspecting of one such terrorist. So this kind of an image we received. So again, how can a forensic dentist help? We know the facial structure in a best possible manner. So we did the image enhancement. We did a lot of forensic facial reconstruction through 2D sketching part. And when we released this specific image, it was identified by the intelligence bureau people. I'm not able to. Okay. This is the last case which was referred just a month back from Gujarat itself, from Gujarat police. They identified a skull and a mandible, and it was referred to us. We did the entire digital documentation, we printed, and we were able to create the face based upon the inputs received from the IO. The face was prepared, and yes, that led to a proper identification. So when we talk about the good part of forensic dentistry, there are some challenges in digitalization part also. The first part is the financial cost. Now, when we talk about CBCT, when we talk about CT analysis, when we talk about 3D softwares, every technology has some kind of cost involved. So a lot of financial costs have been involved. At the same time, there is some kind of temporary loss of productivity. The reason is because we get ourselves, we try to learn that technology, we try to understand, we give more time. So it's like that, it's like better to go for a conventional way rather to work on the digital manner. So there is some kind of temporary loss of productivity, and yes, because when we are sharing some kind of digital data to the offices, there is always chances of privacy and security concern. So again, with this I would like to conclude by saying that digital forensic odontologist, or I would say digital forensic dentist, are competent enough because they have amount of knowledge in terms of craniofacial structures. They are truthful, they do a lot of scientific evaluation, scientific analysis, and yes, as a dentist we have a keen observation. Whenever we talk to people, the first thing what we do is we look at their dentition. Okay, whether there is some kind of spacing, whether it is well aligned or not. So we have a lot of observational skill, and we work on some kind of instrumentation to develop our analytical skills. Communication is one such medium, an important parameter for a forensic expert, because they have a lot of conversation with the local officers of their jurisdiction. And yes, innovation is important. You cannot hold with your conventional theories, conventional techniques. So with this, I would like to conclude by saying digital technologies could revolutionize and reshape the forensic world with appropriate knowledge and utilization of digital techniques. Innovative approaches can be implemented for specific identification in any kind of forensic cases. Thank you for patience listening, and I'm open for any such questions. Thank you.
Thank you, sir, for wonderful presentation. Before proceed to the next lecture, I would like to invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, Dr. Pankaj Patel sir, Dr. Ruchi Patel ma'am on the stage. I would like to invite Dr. Abraham Johnson sir for felicitation. Thank you, sir. I would like to invite Dr. Neha Navid ma'am for felicitation. Thank you, ma'am. I would like to invite Dr. Piyush Shivhare sir for felicitation. Thank you so much, sir. Now I would like to invite Dr. Divij Kular sir for felicitation. Thank you, sir. Thank you, sir. Thank you, ma'am. And I request all the delegates, if they want to go for high tea, they can. So, so we are now again start with the next lecture. I would like to invite Dr. Jasneet Kalra sir. He is an eminent prosthodontist and implantologist. Welcome you, sir.
Good evening, everyone. I wholeheartedly thank Cynodent and PFA for all the fellows. Myself, I am Dr. Jasneet Singh Kalra. I will be speaking on my favorite topic, for which I even held a workshop yesterday, which would be predictability on guided bone regeneration. So I hail from the capital city, and this is what we generally do in our practice. So I've been training and mentoring graduates in the field of dental implantology, and it's been almost 4 to 5 years I've been doing that. I travel abroad and pan-India for all the implant courses and workshops. Basically, I talk more on implant prosthetics being a prosthodontist, but most of the surgeries are done by myself. It's a wake-up call before you guys sleep. All right. Yeah. So my name is Dr. Jasneet Singh Kalra. I have done my diplomat from WCOI, Japan. I am indebted to ITS Dental College for whatever prosthodontic skill I have today. I am key opinion leader with several implant companies. I have been extensively trained for hard and soft tissue grafting by Geislick, consultant with many dental clinics in and around NCR, and I am the premium owner of 2 dental setup, which is in New Delhi. So I'll be covering my topic under the following contents. Let us start. So what do we want? We all are living in this perfect world with all the perfect things around us, and we want a perfect or an easy, I would say an ideal patient coming to us. Ideal cases like these, wherein we have a 3/6 missing tooth, and with that what we look for? We look for rehab, because implant is one thing we talk about today, correct? So we just almost 2 minutes back I was sitting with Dr. Krishna. We were talking about if someone says re-implantation, gone are those days we talk about natural tooth. We talk only and only about implants. So seeing a edentulous single site, I would always plan go ahead and do my osteotomy, open up a regular flap, Osteodensification, further on place my implant. I usually submerge my implant by 0.5 to 1 millimeters so that whatever remodeling needs to be taken place, and further on my closure. Prosthetics, in prosthetics we generally don't use gingival formers or healing abutments. We customize or move our soft tissue as much as possible. Post that, impressions, open tray, I'm a very old school thought. Either I do digital today, which is with the help of scan bodies, or otherwise I go with open tray transfers most of the time. And finally the processes. Isn't it a simple case? Yeah. And by the end, it takes me generally 35 to 40 minutes, I'm minting good 40 to 50K and we all are happy. But the life is not that easy, correct? Whenever we are expecting a mutton or a chicken biryani, this is what we are served in the platter. So what does this mean? What are we served? So cases like these, you move ahead with any kind of osteotomies, you see a buccal dehiscence or fenestration and you land up, you have to do something, maybe play with the bone, do a regular GBR or any kind of augmentation. Or nowadays I get cases like these. I have got a new terminology in my clinic which is known as titanium tattoo. So these titanium tattoos are very regular today. We need to see, guys, what are the 3D implant placement today, and accordingly we see these cases has to go down. It is very, very important. Or maybe a rehab like this. See, whenever a patient comes to our setup, they are implant. Post that, we overfill the graft, but the graft should not be compactly packed. If the graft is compactly packed, you will not have better angiogenesis. It should be loosely packed but overdo your graft because absorption is going to be more. Further on, we use membrane tacks to tug up the membrane. So collagen membrane was used, type 3. We just pulled it from buccal to lingual end, and with the help of membrane tacks, we were able to stabilize it. Post that, we covered up the site with resorbable sutures. So what is that principle of GTR? It is very simple. A membrane has two sides. One is the rough side, the other one is the smooth side. The smooth side, basically, it helps in fibroblast attachment, and the rough side, it helps in osteoblast attachment. So that's a simple principle. You have to exclude both the cells, the bone forming or the osteoblast cells and the tissue forming the fibroblast cells. These are the two sides of the membrane. The smoother side should be towards the tissue, whereas the rough side it should be towards the bone. Coming on to the next clinical case. So again, immediate extraction, implant placement. There was a buccal bone defect, or you can see the buccal bone, it completely fractured in this case. We went ahead, we took the autograft, or we scraped the site, placed the autograft completely onto the site where my implant was exposed, covered it up with xenograft, and then did my membrane stabilization. Here in this case, the suture which I have used is a apically positioned horizontal mattress suture by which we have stabilized the entire membrane. So that is what, if you see the last suture which is placed into the apical side, that is a suture which is holding onto my membrane. If this entire structure can be taken care of, we can predict a better bone formation at least after 4 to 6 months. So a non-resorbable membrane, generally we have these two membranes which are available in the market, DPTFEs and EPTFEs, which are extensive and are dense PTFE membranes. So again, the two sides, the soft side and the hard side, which is my rough side, and in between there is a titanium mesh or foil. Again, a case wherein there was 1/4 missing the first premolar. Generally we have it in the aesthetic zone, and the female who have a broader smile, you will see up till the mesial side of the first molar comes under the aesthetic zone. So in this case, can you see that buccal dehiscence or a C-shaped curvature? So we need not the prime duty was not only to place an implant and rehabilitate this, but we have to take care of this buccal dehiscence also. If we are not able to do that, we won't do justice to our patient. So we went ahead, did a guided implant surgery just to take a punch hole because it was a very narrow space mesodistally. We did that. Post that, I opened up a full thickness flap, exposed my bone, placed my implant using densification, and installed my implant. Once my implant was placed, can you see that grayish hue? That means it requires some kind of GBR. So we went ahead, did decortication. Post decortication, we have placed the membrane, stabilized, did our grafting, and this was the result. And then we placed the membrane, stabilizing sutures, and we started from there. We ended here almost after 4 to 6 months. Further on, we went on to prosthetic phase. Now, if you see in this particular picture, the entire C-shaped deformity was no more. We were able to take care of it just by doing a regular GBR procedure. And that's the final prosthesis. Again, a screw retained PFM. It is not any kind of all ceramic crowns, although we do a lot of all ceramic crowns now. A next case of anterior implant placement, there was a lot of bone loss, vertical as well. You see, according to radiologists, if I could do flattening up to 10 millimeters, only then I would get a flattened bone to place my implant. But then it wouldn't be in a conducive implant, conducive 3D implant placement. We went ahead, we saw, we did osteodensification, implant placement, and the threads were exposed. Again, the same regular principle, we have to cover it up with autografts, xenografts, stabilize the membrane, and we were able to complete this case. So what are the autograft harvesting units? Very, very important. It is not about showing the surgery, it is all about you need to know what all instruments are available in the market which would really help you. Out of one which I use generally is my bone scrapers. There are two types of bone scrapers which are available, the plastic or the disposable ones or the metal ones. The metal ones need to be sharpened with Arkansas stone after at least 4 to 5 surgeries. So it's always better you use the disposable ones because those are more sharper. Or the refined drills which are generally used to remove an implant or cut the bone. I use these drills to remove the bone, piezoelectric units or a simple bone rongers. We have bone rongers in our operatories every now and then. So indirect sinus lift. So in these cases, we have so many options how to go ahead with the case. You can use denser burrs, you can use osteotomes, magnetic mallets. I generally use denser burrs to go ahead and do my indirect sinus lifts. After the LA, we opened up a site. There was approximately 5.3 mm of vertical bone height. Then we went ahead, opened up a flap with my guide drill and my Lindemann drill. I was at least short of 1 millimeters. From there on, introduced the denser and I start lifting my site. Post lifting the site, we have placed bone graft. You can see the patency of my bone graft. This is basically any kind of tenting or umbrella effect what you see. That is how you can be sure that your membrane is absolutely patent. Once we have done that, we place our implants. And now this is covered from all the 4 sides with the bone. A second case wherein I am showing you a video of direct sinus lift, how to do best or how to go about with the direct sinus lift. A video will show you. So in this we generally make a lateral window, and through this lateral window there are specialized curettes. We keep on separating the Schneiderian membrane from the underlying bone and we keep on pushing it away as much as possible. And then we introduce the bone graft. Opening up a full thickness flap. The blade which I generally use in each of my surgeries, it has to be a 15C blade. And then with these diamond drills, we start preparing the lateral window. So once this lateral window has been prepared, we'll move on and we'll intrude the sinus and we'll start separating the sinus or the Schneiderian membrane. And we have to be very, very gentle once we are using these kind of instruments or curettes. Now you can see with Valsalva, my membrane is absolutely intact. I have a very special way of separating or lifting my membrane. I straight away do not put my bone graft. I use a collagen membrane which I will be introducing now, and with the help of that collagen membrane, I will be separating my Schneiderian membrane completely. So first we will be drilling, keeping our membrane absolutely separate from our drilling sites. And you can use stoppers, where if you have to go 2 to 3 millimeters only, you have to be very careful. You cannot puncture the Schneiderian membrane at all. Now with the help of this collagen membrane, I am lifting my Schneiderian membrane completely. So I use generally 2 membranes, or what I do is first side I use my membrane, place my graft, and then I use collagen onto the top. Like in this case, taking up the bone graft in completely, and then finally I'll cover up the side with the help of collagen. The implants which I have used here is from Dentium. Those are the bright implants which are recently introduced, very active implants. And you can see a good primary stability of approximately 40 to 45 Newton centimeter, which is good enough for immediate immediate loading also. But since it was a complete sinus augmentation, I prefer doing a delayed loading. So in both the implants, we got a very decent initial torque. So after this, whatever window we have created, I'm closing this with the help of collagen instead of using a collagen membrane. So this collagen has got bone graft and type 3 collagen. So we'll completely condense this or push this onto our window and it will be completely closed. The soft tissue needs some type 2, type 3 collagen. Only then it won't creep inside the hard tissue. And then the sutures. Generally I do layered suturing. I've stopped doing regular interrupted sutures. And finally, a case wherein there was maxillary internal resorption. We went ahead, we did collagen, with implant placement, autozeno, and we closed the site. Again, a case, I'll just show you the prosthetic part of it. The surgical part is absolutely same. We did all the implant placement, and then after 16 weeks of healing, we were able to achieve this kind of emergence profile. So for any, especially in case of 1121 missing, we need a broader emergence profile to get a better results. Post that, we went ahead and did open tray transfer. We went ahead and did the jig trials. Jig trials were absolutely perfect. What we planned here was a good, my titanium customized abutment and onto the top a Emax crown. But my access hole was again onto the palatal side. So wherever possible, I try placing my implant as palatal as possible to get a conducive screw channel. And that was the final smile of my patient. We started from here. This is with the customized abutment. And we ended here. So it's not only about implant placement. It has to be a better prosthetic result which our patients are looking for. A final case wherein the lower anteriors, I generally place one implant if there is 3141 missing, because the inter-implant distance has to be taken care of. So generally there is a mesial cantilever what we give in those cases. So again, my implant should be at least 3 to 5 millimeters from the CEJ or the plant contour. It has to be between 3 to 5 millimeters. The same concept, first autograft, xenograft and the membrane. And finally, so this is my last case, video just to show you how do we do vertical augmentation also using Khoury's technique. So for a predictable guided bone regeneration or any kind of regeneration, you need to know what are the basics and in what case what works. It is not only the GB or the membrane or the graft would work. So in these cases, what we did is we basically harvested the bone shell from the molar side and we have placed it onto our anterior mandibular anterior side. The lingual flap was completely raised so that only then I can have a better closure or approximation. So removing the bone shell from the premolar side. And from the side you have removed the bone shell, it's always better to place a graft and a membrane so that the bone can be regenerated in that area. And the screws by which we are able to stabilize, these are osteosynthetic screws. This is it. So we stabilize the entire bone shell with the help of these screws. And a regular GBR after placing the shells. And you need to use a resorbable sutures in these cases. Thank you so much. Every ending is a new beginning. You can connect with me on social media. Thank you.
Now I would like to invite Dr. Ruchi Patel, ma'am. She is all the way from Kenya, and ma'am, you are such a wonderful personality. Topic for this session is the oral microbiome and its role in systemic disease and sleep medicine.
Hi, hello. Is it on? Okay, great. Hello, everyone. Thank you so much for waiting into the afternoon. I know that after those gulab jamuns, I'm definitely struggling to stay awake, so hopefully I'll keep this a little bit more lighthearted for you. My name is Dr. Ruchi Patel Sahi, and although I am a dentist, like a lot of the amazing restorative clinicians, it's a little bit of an offbeat lecture on what I feel undergraduates miss out in training and what a lot of us as dental practitioners are not giving enough importance to. So we're going to be talking a little bit about the oral microbiome and sleep medicine, which is my speciality. So this is how I thought I'm going to capture your intrigue. This is me after graduating from dental school. Beautiful picture here, and I was not in good health. Borderline diabetic, hormonal issues, you know, as long as you could say, and definitely overweight. And I just didn't feel healthy. And after studying dentistry, as you all know, we're virtually medical practitioners. So how could I be like this and preach health to my patients? I went on to do a degree with the American Academy of Aesthetic Medicine, kind of in a pledge to figure out how I could get healthy. And what I did find, I'm going to talk about in this lecture because it's a very personal journey. I'm here to talk to you about it because I am an outcome of what I've gone through. And I believe to make yourselves authentic practitioners, you need to understand this as well. So let's get started. Some facts. In 2018, Harvard University did this study that came up with 5 healthy habits that could add 12 to 14 years to your life expectancy. No surprises here. Eating healthy, exercising, maintaining a healthy body weight, not smoking, and not drinking too much alcohol. But what a lot of people didn't know was having a healthy mouth can actually increase your life expectancy by up to 10 years, and having a healthy airway can increase your life expectancy by another 15. So hold on a second, what are we saying here? That actually just the development and health of your mouth can actually increase the life expectancy of all those go-to combined. That is a big, big undertaking you as dental professionals have for your patients. So I practice holistic dentistry, and no, it's not alternative dentistry. Holistic dentistry is encompassing total body health, and I know you have great clinicians here in the periodontology department who talk about systemic disease and inflammation, which is what I'm going to talk about today. We have the soft tissue in the mouth and we have the hard tissue, and for the practitioners who focus on hard tissue, fantastic, we need to do that. But I feel so often the soft tissues, or why we got there in the first place, is something that's quite underrated in clinical practice. So we want to look at the root cause, not just how do we replace this missing tooth. Hold on a second. Why does this patient at this age, if it's not something to do with trauma, even have this problem in the first place? Let's put pause on fixing the missing tooth. Let's fix the reason, and you can actually change this patient's life. So when you're in your mother's womb, you're completely sterile. There's no bacteria in and around you. As soon as you're born, down the birth canal, C-section, whatever, you start to accumulate bacteria. What we have found is when you are the adult that you are today, the number of bacteria in and around you outweigh your genes by 360 to 1. So in medicine, when we were only looking at genetics, only looking at family history, why do we get diabetes? Why do we get disease? We were missing a trick because the microbial genome was getting ignored. And there's a group of pioneering biological medics in the US who said, okay, if you're correct, let's forget about genetics for a second. Let's see what happens when we start to play with this microbial genome. and something was born called the gut microbiome. Everybody here probably knows it. Digestion is key. If you've got a good gut, you've got a second brain, all of that. But dentists know that you have direct access into the beginning of the gut all the way down to the other end, and the oral microbiome can harvest the most amount of pathogens than anywhere in the human body. This is very relevant. So the mouth really is the gateway to your body. As you know, a healthy mouth can really get you what you need, and there's broken it up into two sections here. One is about the oral microbiome, which is my specialty, but the other one is also my specialty, which is about airway, which is getting the correct amount of oxygen at night when you sleep, and sleep medicine as dentists, which is something that very few dental schools even currently are being taught. So we're going to start by talking about this mouth-body connection, and I do know that a lot of dentists know the basics. We know about a heart condition and perio. We know that it affects diabetes in a bidirectional relationship, but the slightly more unknown things are research that was done shows that people with chronic gum disease have, for more than 10 years, have a 70% higher risk of dementia and Alzheimer's. I'm going to expand on that. Harvard University in PubMed released a paper, 20 years in research, that said dementia and Alzheimer patients had bacteria from the oral microbiome, and they said they had gum disease. So this is now showing we're going a lot deeper. A lot of us don't look at respiratory disease as a link to periodontal issues. Cancers is definitely a huge one, and rheumatoid arthritis. So there has been this flood of scientific data that your oral health does impact your physical health, and it is actually being rewritten as we speak. But let's go back a little bit. As early as the 5th century, you heard from Hippocrates, all disease begins in the gut. Let's look at 1891. A microbiologist named Miller published a paper that says the human mouth is the focus of infection. Obviously that skyrocketed into the focal infection era. Then in the 1911, an English physician, William Hunter, said oral sepsis as a cause of disease and blamed dentistry for chronic disease. Moving forward, 2011, the United Nations for the first time ever associated oral disease with significant morbidity. This is only the second time ever that it has brought up in a UN summit, the first one being AIDS. So, cardiovascular disease. This is something that as a dentist still shocks me today. The statistics, 50% of heart attacks are triggered by bacteria in the mouth. Does anyone here know someone who's had a heart attack? 50% is triggered by bacteria in the mouth. That is a statistic that is too harrowing to ignore. People with gum disease are 3 times more likely to die from a stroke and twice as likely to die from a heart attack. This is from the Mayo Clinic. We know how, but how much do we screen this with our patients? Diabetes. Diabetes with bleeding gums increases your risk of premature death by 400 to 700%. Not something to be messed with. Of course, we know about the bidirectional relationship where inflammation can exacerbate diabetes, and diabetes is also a root cause. But this is something that I feel a lot of undergraduates probably wouldn't have touched on, which is respiratory infections. Poor oral hygiene can increase the risk of pneumonia and respiratory infections. This is you as a dental practitioner looking into your patient's mouth and giving them a risk factor for diseases that are life-threatening. So let's look here at, in 2021, this was very relevant during the time of COVID, and it suggested that patients with gum disease were actually 9 times more likely to die from COVID-19. And they also found that people with periodontal disease were at least 3 times more likely to be admitted into ICU and 4.5 times more likely to require a ventilator. It's very serious. Rheumatoid arthritis. As we have inflammation in the gums, and this inflammation travels in your arterial blood supply and reaches certain parts of your body, the same inflammation can mean that rheumatoid arthritis has a direct link to periodontal disease, and there was a paper that is studying this link in such a way to say that rheumatoid arthritis can even be treated, prevented, or cured by maintaining the oral microbiome in the first place. This is the research that is happening currently. We also know about issues in pregnancy and gum disease and periodontology, so we know about that. This is something else, cancers. Researchers, again at Harvard, found that people with a history of gum disease actually have a 43% higher risk of esophageal cancer and a 52% higher risk of stomach cancer than people with healthier gums. That is more than half. 52% are at higher risk. That is a big deal. So I want to put this a little bit in perspective for you. I know you've seen lots of amazing clinicians fixing lots of serious problems. However, if as a dental practitioner, you are not taking the time to fully diagnose the effect of the periodontal, the soft tissues and the periodontal disease with your patients, we are saying that young men under 50 with advanced perio are 2.5 times more likely to die prematurely and 3 times more likely to die from heart disease than those with healthy mouths. So it shouldn't be brush and floss to save your teeth, it should be to save your life. I want to talk about sleeping, which is the second part of my specialty, and it's always about the airway. We all know about yoga, we all know about pranayama. A lot of us understand the power of oxygen, the power of breath, why it's so vital for your organs. But do you know at night when you're sleeping, this is when your body needs the highest level of oxygen, and it needs it in a pattern of sleep that's called uninterrupted sleep. Any form of interruption in your sleep means there's a slight drop in oxygen in your brain. Suddenly your parasympathetic and sympathetic nervous system starts to fire up, and via neurotransmitters it starts to send signals to wake the organs up, so to speak. When this happens, your body goes into overdrive, and what is happening is you are not falling into REM sleep. If you are not falling into REM sleep, then your body is slowly deteriorating. And as we age, we then start to worry, oh, I'm getting older. But 20 years of interrupted sleep means your body has got 20 years of a deficit of oxygen that could have been prevented. And how could it have been prevented? By dental practitioners. You have first access into the airway, and you really need to understand the importance of what you're looking at. So we have so much in life we need to think about. We're not thinking about how we're breathing and why we're breathing. But as you all know, the evolution of the airway starts way before, in utero, even before you're born, and develops at every stage. When it gets compromised, when the development gets compromised, this is where we start to see changes that can actually affect our entire health. I'm going to talk about why it's so important, but if you look at the child's generation, every time you see a malocclusion, a lot of the times you're just seeing a malocclusion. You're not talking about how is this child sleeping. And actually what will come about is the pressures of the soft tissue are actually what determine malocclusion in developing dentition. So if you're not looking at the soft tissue and you're not intervening, then you're not increasing oxygen in these children, and they will be a victim to it. So snoring, gasping for air, these are actual signs of struggling to breathe. These are not the joke that it once was, my partner snores, it's irritating. This is an actual interrupted sleep cycle. So drop in oxygen and excess of neurotransmitters, and it sends everything haywire. So the earlier in life we experience this, the more the negative impact will be later on into our older age. Dentists, you really can help your patients breathe better during sleep. So what we want is this optimal airway. You're looking at wider jaws, the tongue tone, the tongue in the correct position in the mouth. This is what improves nasal breathing. You get proper nitric oxide oxygen exchange, and you get restful sleep. This is the key slide, to be honest. The jaws, the lips and the cheek, the tongue, how you swallow and how you chew at an early age will actually determine how the jaws develop. And if you are not getting ideal development, you are getting malocclusion. A lot of dentists I'm still seeing today are telling children, parents of children, wait until the child is 12. Wait until the child is 12 and come back to me. We'll refer to ortho, we'll create some space, and we'll give you a beautiful dentition. 12 is too late. The jaw is fully formed. What about the incorrect soft tissues that you can correct from the age of 3? What happens when you put the tongue in the correct position? This child starts to breathe better at night. Aside from the behavioral issues, which I'll come to, they actually get a chance to develop their jaw effectively and prevent malocclusion in the first place. The World Dental Federation in 2019 actually said this: universities and national dental associations to provide students and dentists with basic knowledge regarding the important role of dentistry in preventing and treating sleep-related breathing disorders, in particular early detection in children and the prevention of the late onset forms. It is the duty of care of any dentist to actually be screening for sleep-related breathing disorders. I wonder how many dental practices actually have a sleep medicine questionnaire in their waiting room attached. It is a duty of care, and you need to widen your knowledge on this because it is becoming more and more relevant. Research has indicated that 9 out of 10 children have at least one outward symptom of sleep-disordered breathing. As we get older, there's an increased likelihood of breathing through the mouth. Did you know that mouth breathing is a sleep-related breathing disorder, which means literally if you fall asleep and your lips are not closed, you're getting a decrease in oxygen and you're not falling into REM sleep. That's a big problem. People over 40 anyway are 6 times more likely to spend more than 50% of their time sleeping with their mouth open. And mouth breathing makes it 2.5 times more difficult to breathe the correct way. And this is the key. Everyone said, well, how did you do it after you were a dentist? It's an important adjunct to losing weight, for your metabolism, for your neurotransmitters to balance. It is absolutely vital that you sleep effectively. So what do dentists want? What do we want? What do you want as people? You want full-on nasal breathing. We want 24/7 nasal breathing so that we can increase oxygen saturation and you can fall into this REM sleep. So it could, this is what I tell a lot of my parents, but it could even apply to you. Do you or your children snore? Do they grind their teeth? Teeth grinding. Teeth grinding is the biggest underrated looked at thing, because we tend to just take a beautiful impression and give the patient a night guard, but nobody's questioning why are they doing it in the first place. Stress doesn't cause it, stress exacerbates it. What causes it is the developmental soft tissues that we ignored in our patient, and there is something that actually all of you could be doing about it now. Children, behavioral issues, we'll come to that in a second. Bedwetting, anxiety in children, mental health issues, things like asthma and allergy becoming really big in our child population. Nobody is wondering where this is coming from, but we know it is coming from the fact that they're not getting enough oxygen and they're having a difficulty breathing. No, your child grinding their teeth during sleep is not normal. I hope none of you have ever said that before. And no, they will not grow out of it. Common is not normal. Have any of you had parents who have said, hey, guess what, my child grinds at night, is that okay? And you said, oh, I'm sure it's okay. Once they're old enough, we'll give them a guard. It's not okay. It is a sign of soft tissue dysfunctionality, and you need to be addressing that. So, how do sleep-related breathing disorders affect behavioral issues? It interrupts the restorative sleep, there's a decrease in oxygen, and then you get poor function of the brain. I say this to all my parents. In 2012, a study was done that showed children with sleep-related breathing disorders were 40 to 100%, that's the category you're looking at, more likely to develop neurobehavioral problems by age 7 compared with children without breathing. So if you are telling parents there's nothing much to do until your child is older, just a routine, little clean, little sit on the chair, you're wrong. There's a lot more that you need to be looking at. The journey starts when the parent or your patient or the child is in the waiting room. How many of you have peeked out of your door and they're like this? Mouth breathing. You need 24/7 nasal breathing. Mouth breathing means you are suffering a sleep-related breathing disorder. That has been categorized. Now, how much you want to do about it, that's going to be up to you. When you're a chronic mouth breather, you start to notice this profile. So a lot of patients say to me, really? This is changing my face? So I don't know if you remember, my pictures of, pre my journey, a lot of patients say, well, you don't even look like that. And no, I haven't had the pleasure of meeting the top facial esthetician in Delhi yet, but, I did correct my soft tissue issues. I was a grinder after dental school, and it completely changed my entire profile. So, children that sleep like this, any of you to have children to come or know any children, take a picture of them. 2:30 a.m. in the midst of their deep sleep cycle. If they're like this child will have a malocclusion. If you can correct that, get them proper tongue position, proper lip seal, you can prevent a malocclusion. This is what this is about. So, you can see how the profile changes from a mouth breather to a nose breather. It's not, everybody's beautiful. It's about functionality and health and giving you the correct growth of your jaws so that you experience that good health. So when we mouth breathe, once again, we know we get this kind of setback jaw, smaller airways, crooked nose, higher prevalence of asthma, higher prevalence of allergies. This is because everything is all constricted. When your tongue is not sitting on the roof of your mouth and it drops down, the jaw widens. And so what happens is you get this narrowing of the sinus, and this is where all the problems come from. So again, you could really be preventing this. Mouth breathing is also integral into the oral microbiome. You know that dry mouth causes so many issues with hard tissues, but it also causes so much in terms of inflammation in the mouth. This is what we need. Lips closed, tongue on the roof of the mouth, nasal breathing, day and night. Even during this entire lecture, this is how, no one is opening their mouth now, which is fantastic, but this is what you need to be doing, okay? Even if you're doing this consciously, at this stage in life, you are training your soft tissues. So I just want to connect the dots for you. A study that was published in all WH regions in 2020 said the top 2 reasons that patients go to a dentist is either they're in pain or they want to straighten teeth. Here are some of the things that I think are getting pushed to the side, okay? Bleeding gums, airway obstruction, mouth breathing, sleep disordered breathing, tongue or lip tie, tongue thrust, thumb sucking, nail biting, facial growth, lip incompetence, clenching, grinding, profile speech, dry mouth, bad breath, snoring. Now, I know some of you think, oh, I'm sure my patients talk about a few of these things, but the focus on these things is getting left behind when you're simply focusing on fixing the problem. This is more the root cause, and I urge a lot of you to look for treatment options for things like sleep-related breathing disorders. I myself am a myofunctional therapist. I have been doing it for 15 years. Myofunctional therapy works on increasing the strength of your muscles of your head and neck, and it can be used from birth all the way up into adulthood. When I say from birth, I mean removing pacifiers and giving children hard items to chew on so that you work on the myofunctional effectively, all the way up until adults, where we actually treat sleep apnea clients, which is obviously the more serious end of the spectrum of sleep-related breathing disorders. CPAP machine surgery, change your lifestyle a little bit. Those things are slight, but you need more work with muscles if you are really going to change the development of the structures of the face. So a little poem that I love: in order to smile, you have to feel good. In order to feel good, you need to sleep well. In order to sleep well, you have to breathe well. And in order to breathe well, you have to breathe healthy. And in order to breathe healthy, you have to nasal breathe. I hope that shed a little bit of light on what I do for you. It's too short a time to summarize it in a lot more scientific detail. But, you know, your life really depends on your mouth, and as practitioners of this day and age, really take that a little bit more seriously. Try and understand that you are going to be changing these patients' lives, even medically, even in the future, not just what you're doing with the problem that they walk into your clinic with. Thank you very much. These are some of my details, and thank you for listening on this late afternoon when everyone's super tired already.
Thank you, ma'am, for wonderful session. Now I would like to invite Dr. Neha Navid, ma'am. She is orthodontist, and topic for this session is 10 key orthodontic principles for smile excellence, balancing aesthetic and function.
everybody present here today. Let me start by introducing myself to you. I'm Dr. Neha Naveed, a consultant orthodontist from Chennai, and it's been a privilege to be here and to be inducted here today. I would like to thank Dr. Anmol and the entire team of 12th World Dental Science and Oral Health Conference for giving me this prestigious platform in KGMU Lucknow and share my insights to all of you. And it's been a pleasure to be inducted as a fellow of PFA also today. And my journey with PFA actually began in 2018 when I was there at the convocation and I was honored with the undergraduate student award. So to be there and to be here as a fellow today, it's been quite a journey and it really does feel nice. And without much ado, I would like to start with the lecture. And the topic for today's lecture is 10 key orthodontic principles for smile excellence, balancing aesthetics and function. So as an orthodontist, I feel that to craft beautiful smiles, it's always an amalgamation of balancing both aesthetics and function. And I have always believed that orthodontics as a specialty, I would call it as the art and science of orthodontics. So it is not just, knowing the science behind what you do, knowing the sound scientific principles, but also you need to know that it's a lot about the aesthetic impact it has, and you need to also have an artistic eye towards whatever you do. They say you cannot treat what you cannot see, right? So it's just not about placing brackets and just moving the teeth, but you need to have an artistic eye, the smile that you aim to achieve, because most of the people who are here, they are coming to you not just for beautiful picture perfect smiles, but also for happy smiles. So it is always a mixture of both aesthetics and function. So to begin with, let's move forward. So what I would like to so this is one picture of a patient that I had treated, and I find great pride in because this patient was delighted with their smile. And as doctors also, it does seem very satisfying, right? When your treatment that you do has a big transformative impact, it does leave a lasting impression on you as well as your patients. So to achieve such smiles, to gain the excellence in smiles, what are the principles that you need to follow? So when a patient walks to you, it's not just the clinical examination or the radiographic examination that you do. I always also do an aesthetic examination. So this is a very subjective thing. It's not a very objective thing, but still I have jotted down into points what are the things you need to keep in mind when you're doing this aesthetic examination. So the aesthetic examination is nothing but examining your patient's smile. So to break it down, so what is the anatomy of a smile? So when you look at a patient's smile, you have the two components basically, the pink aesthetics, the white aesthetics, that is your check. Yeah, I'll just use this. So I just said that there are two components of a smile, that is your teeth and your gingival scaffold. So the display zone of your smile is draped by your upper and lower lips. So we are not just moving the teeth to the right position, but also you have a lot of soft tissue determinants in the display zone. So this is dictated by these four soft tissue factors: your intercommissural width, the lip thickness, the interlabial gap, the smile index, which is nothing but the ratio of the width of your smile to the height of your smile, and the gingival architecture. So in this lecture, I'm just going to talk about these 10 commandments of smile aesthetics, or in other words, what are the ideal characteristics of a smile, or what should be assessed in a smile. So moving on to the first point, which is the smile arc. The smile arc is nothing but the positions of your maxillary incisors in your vertical position. So this smile arc is defined by the contour of your incisal edges of your maxillary anterior teeth in relation to the curvature of your lower lip during a social smile. So generally it can be categorized as a convex smile, a straight smile, or a reverse or an inverted smile. So what is actually aesthetic? It is the convex or the consonant smile arc, right? If you see the picture on the right hand side, the straight smile arc or the inverted or the reverse smile arc doesn't really look very aesthetic, no matter how properly aligned it is. So this smile arc is a very important determinant. So what exactly happens here is the lateral incisor is always going to be 0.5 to 1 mm shorter than that of the central incisor. And this step, it varies between male and female. It's slightly more exaggerated in women than in men. So when, as a practitioner, how do you, modify this, or how do you come to terms with this smile arc? How do you modify it? So in this particular case, you can see the aesthetic impact that it has just in the changes of the vertical positioning of incisors, right? Nothing much was done. The teeth are fairly aligned, but just by altering the smile arc, you can see, like from the first picture to the final picture, it does have an impact, right? And in the current scenario, we do have a lot of digital softwares, for smile designing, which are an additional aid for us. And another tip on how to achieve this, especially with orthodontics, is we have this concept called as the smile arc protection. So this is a concept that we follow at the time of placing the brackets itself. So in the smile arc protection, when we place the central incisor brackets, we place it 1 millimeter more gingival than the canine brackets, and the laterals are somewhere in between. So instead of placing it exactly at the center of each tooth and achieving a straight occlusal plane, when we follow this way, where the central incisors are bonded slightly more gingivally, when the teeth get aligned, you get this proper consonant smile arc, right? So this is the first determinant of achieving an ideal smile. So when I showed the first picture, you can see now each commandment that I talk about, how you can correlate it to the picture that I have shown. This is a consonant smile arc, right? So the second one is the ratio and the symmetry of your central incisors. So there is an ideal height to width ratio. So ideally it's supposed to be somewhere between 75 to 85%, which means let's say the height of a central incisor is 10 millimeter. The width would be somewhere around 7.5 to 8.5 millimeter. When this ratio is altered, it gives rise to teeth looking more longer than natural or much shorter than natural. Both are not considered to be very aesthetic. So that is why the role of this ratio is important. And again, it differs, the preferences between male and female, because slightly more wider teeth are accepted by men, but women accept a slightly more longer teeth. And how does this play and role, this ratio? Because it's not just about aligning teeth, it's more about an interdisciplinary approach. If you feel that this ratio has been altered, you need to do adjunctive techniques, such as maybe a crown lengthening, a gingivoplasty, or even a build-up with composite. So to achieve that ideal smile, it's not just about, a single approach, but you need to think of it in a more multidisciplinary way. The third component that I'm talking about is the proportion between the teeth. So nothing that is out of proportion looks appealing, right? Proportion is a very important aspect. And if you've heard of this golden ratio, anything that exists in nature, may it be a beautiful flower, or may it be, very renowned architectural buildings, or even the painting of Mona Lisa, anything that has been considered to be aesthetic follows this golden ratio or golden proportion. It is the same with our dentition also. So our teeth also follow this golden proportion, where if you see the ratio between each of these teeth that are visible in the display zone, they follow the 0.6:1 ratio, which means your central incisor appears to be 62%, a little more bigger than your lateral incisor. The same with the canine. I don't mean the entire mesiodistal width of canine, but just the display portion, because just the mesial half of canine is there. So even if this ratio is altered, it is going to alter your smile aesthetics. Let me explain it to you with a clinical scenario. So if you see this picture of this patient, you can see that this golden ratio is altered. You can see that the lateral incisor is much smaller in size. So this is not proportionate. So there are two ways that you can correct this. One reason because of this lateral incisor being shown very minimally can be because the lateral might be rotated. So by just derotating it, you can achieve this ideal golden ratio. Or it can also be that it's just smaller in size. So in such cases, you need to plan for, a veneer or a build-up, a composite build-up. So when you identify this only at the beginning of treatment, that's when you can plan for it and proceed for it and achieve your treatment goals towards the end of treatment. So just by altering that golden ratio, you can see that this patient has a more proportionate smile. Then again, back to this picture that I showed you, you can see, now you can appreciate that golden ratio being maintained here, right? Right from the central incisor to the canine, it just keeps proportionately varying. So the fourth one, here it's a very simple one, which is the presence of interdental spaces. So this commandment just says that any spaces are deemed to be anesthetic. Nobody likes spaces between the dentition. And it's not just with it's not just from a dentist perspective, even the lay persons, they identify spaces and it's considered to be anesthetic. And even according to, the keys of occlusion, the Andrew 6 keys of occlusion, one of the keys is absence of any kind of interdental spaces. So there should be tight contacts between all teeth, and particularly when it's affecting the display zone, that is the anterior teeth, it definitely needs to be corrected. And these are very simple cases which show that just by closure of the interdental spaces, what a great transformative impact it has. There has not been any major mechanics or any, complex treatment, but just by this simple thing, you can see that definitely it improves the aesthetics of the teeth. Now, the next one is the gingival architecture. As I told you in the beginning, we have the pink aesthetics and we have the white aesthetics. There's so much to talk about the white aesthetics as dentists, the proportions and, the position of the teeth, and there's so much. But also the gingival architecture plays a very important role. So we do know that this terminology called gingival zenith, right? That is the highest point on the contour of every tooth on the gingival margin. So these gingival zeniths need to be leveled at a particular way for it to look aesthetic. So always the lateral incisors gingival margin is going to be 0.5 to 1 mm below that of the canines and that of the central incisors as well. So when this is not, in proper matching level, what do you do then? Like let's see the picture on the right hand side. You can see that there's a mismatch in the gingival level, right? Although when you see the incisal edges of the teeth, they are properly aligned. So this again is not going to look nice when a patient smiles. So there are different ways you can approach it. Either you can do a gingivoplasty of the lowest incisor and make the gingival levels match. Or you can either do an intrusion of a tooth so that that gingival level moves up and then do a restoration incisally. Or you can just do an extrusion of the longer tooth and do an enameloplasty. So all this differs case to case. So it is a very a case by case decision, and there's no hard and fast rule that this is what we need to do. So we need to actually examine and see where the fault lies so that you'll know how you can modify it. So it's not just the gingival levels or the zeniths, but also the amount of gingival exposure, most commonly called as gummy smiles, right? So a lot of patients come for treatment for gummy smiles as well. So again, the gingival exposure is classified as a high smile, a medium smile, or a low smile, depending on how much gingiva is visible. Ideally, the entire length of your teeth need to be visible with your interdental papilla. So if anything more than that is visible, that's called as a gummy smile or a high smile. And anything lesser than that is called as a low smile. So anything more or less is not good, because when there is a low smile, it gives the perception of an aged appearance, right? It doesn't give a very youthful appearance to the smile. So therefore we need to maintain this, and there are a lot of different treatments that can be done. As an orthodontist, what I would think of is intrusion of teeth, or maybe a gingivoplasty if the crowns are really small. So we need to again see what the etiology would be. So you can see the list of enumeration that I've done there about the etiology of gummy smile. It can be because of various factors apart from your teeth and gums. It can be because of your lips as well. When you have, an elevated lip curtain, some patients have hypermobility of the lips. So ideally there is no vertical excess, or there is no short clinical crown height, but it's just because of the smile drape, the lip curtain. So in that cases, you need to again think of your facial aesthetics, such as Botox procedures. Or if there's a very thin lip, you can think of a filler. But again, it's always very important to see the etiology of the gummy smile, to not treat it in a very straightforward way. You need to treat it according to the etiology only. And again, when the reason is a low smile line, you need to again think of, elongating the teeth. You need to increase the display of the teeth. The incisal display needs to be complete to give the youthful appearance. The seventh commandment for smile aesthetics are the buccal corridor space. Again, what are the buccal corridors? These are the lateral negative spaces, or the black triangles that you see at the corners of the mouth, at the intercommissures of the mouth. So again, you have a wide buccal corridor, or you can have a narrow one, or a average intermediate one. So when you notice that there is a wide buccal corridor space, that is actually an indication that the arch can be expanded and patient can benefit and get a nice full toothy smile from it. Generally, the narrow buccal corridors, as you see in the picture, was not generally preferred until very recently, particularly in the US, where people like broad arch forms and they like that complete visibility of molar to molar teeth while smiling. But we stick to the average, where you don't have too much of buccal corridor excessive space. If it's there, then you know that you can expand the patient's dentition. The eighth commandment is about the midlines and tooth angulation. So dividing this into two things. First thing, you look at the midline. One can be the midline shift, or it can be the midline diastema. So the midline diastema again is one of the most common reason why people seek orthodontic treatment, because nobody likes a space at the center of their teeth. And there have been a lot of studies that have been done to compare the perception between, orthodontists, between general dentists and lay people regarding smile aesthetics. So any amount of midline diastema was deemed to be very unaesthetic and needs to be corrected. But when it comes to a midline deviation or a midline shift, right, most of the midline shifts were not noticeable by lay people, sometimes noticeable by general dentists and orthodontists. So when the midline shift is just bodily, let's say to the left or to the right of the facial midline, it's not considered a very big aesthetic problem. But if the same midline is angulated, that is easily identified by lay people, and people find it to be very unaesthetic. So from this we know that minimal, 1 to 2 millimeter of midline shift is not a problem. But if there is an angulation, as you can see in the pictures there, the 4 pictures that show you is just a midline shift to the left or to the right, which is not much perceivable. But when you see the midline being angulated, that is slightly, that is immediately noticeable, and that needs to be corrected. Now the second last commandment for smile aesthetic, which is the tooth color and anatomical shape. So a lot of patients, they come to asking for pearly white teeth, that they want white teeth and they want to do bleachings. But most of them don't realize that in a natural dentition, it is okay for the teeth to be slightly yellowish and progressively becomes more darker as the teeth go posteriorly. In the sense, the central incisors are the brightest teeth, the canines are slightly more yellowish, and as you go posteriorly, the teeth become more warmer in hue. So this actually is considered to be very natural and aesthetic, because it gives that perception of depth to the smile, rather than if you see patients who have these crowns or veneers which are like white from premolar to premolar, you can see that it gives a very unnatural and artificial look. So that's where you need to, make your patient aware that in the natural dentition, the teeth slightly become yellowish as the teeth go progressively posteriorly. So that was about the tooth color. The anatomical shape, we did see about the golden proportion, we did see about the height width ratio, but there's another thing that we need to look at is which are the connectors and contacts. So the contacts in the anterior teeth are going to have more surface area and slightly keeps reducing as you go posteriorly. And gingival to this, all the embrasures need to be filled with your interdental papilla. So this is the normal anatomy of the smile, of your contacts and your embrasures. But what happens if these embrasures are not filled by your interdental papilla? It can be because of various reasons such as, bone loss, perio reasons, or it can also be because your teeth contacts are variable. So if you look at this particular case, the interdental papilla does not fill in the middle, you can see the midline. So that results in a black triangle. So this doesn't necessarily mean that the patient has bone loss or this is a sign of a periodontal issue. It can also be that the contact area has been altered. So if you see the contact area over there, it has like a point contact incisively. So the same thing what you can do is, if you do a little bit of an IPR, create some space over there and close it orthodontically, you can close these black triangles. So you don't really need to do a grafting procedure, it's just that you need to modify the shape and form of the tooth. That's why I told you cannot treat what you cannot see. So all these are things we need to identify right from the diagnosis. That's when we need to spend the most amount of time examining the patient's teeth, so that you know step by step how to correct each of it and progress with your treatment. Coming to the last commandment, which is not your teeth or your gingiva, it is the lip volume. And why does this play a very important role in smile aesthetics? So currently, if you see, according to the current standards, people do appreciate slightly voluminous lips with a little bit of a natural pout, right? Now, why is this lip volume important? Two aspects to look at it. When you're planning a case, let's say patient has a crowding of teeth, or let's say patient has proclination of teeth, and you plan for extractions, but you don't notice the lip. So if the lip volume is reduced and you plan for extractions in such a case, you're further worsening the patient's soft tissue profile, right? So that is why it's very important to notice this lip volume when you're planning for treatment. And let's say that the teeth are okay, they are crowded, but you can afford to procline it more. That can in fact help your lip volume. So when you're planning for, space closures or moving the teeth back, always look at the lip volume, because both are, proportional, directly proportional, the position of your incisors and the position of your lip. So when the lip is thinned out, as you can see in the picture at the bottom, that the patient was treated without any, extractions or pulling back the teeth. The teeth were slightly allowed to procline a little more, so it gave a better profile for the patient. And in the same way, if you see, this is a contrasting scenario as the case is on the right. If you can see that the lips are very prominent, and by just retracting the teeth, you are getting a more, an aesthetically pleasing profile when the lips go back to rest. So both are, correlated, the position of your incisors and the lips. And this is a very underrated aspect where people easily neglected the lip volume when you're planning for smile designing. So given the time constraints of like 20 minutes, this is all that I could try to fit into the lecture, and there's a lot that I could still talk about, but I would like to conclude after discussing about these 10 commandments that any kind of smile transformation, if you see, you can see that all these 10 commandments need to be followed. So when you look at these, before and after pictures of patients' smiles, you can see, I've spoken about the smile arc, which you can see in the first picture. You can see the closure of interdental spaces. You can see the ideal display of your gingiva, the teeth, and that's the secret behind getting an aesthetically pleasing smile. And the closing remarks, I always believe good things take time. And as an orthodontist, you need to believe that, because of course you do know these are long procedures, and you as well as your patient needs to wait for a long period of time to see good results. These are not things that you see instantly. But as we know, there are no shortcuts to success. There's no easy way to success. And a lot goes into planning and executing things so that you can give that beautiful smile to your patients. Thank you very much for your patient listening. And you can connect with me on any of the social media platforms. I'm known by OrthoTales on Instagram. And you can also read my research work on ResearchGate. And feel free to reach out to me and discuss on anything you'd like to. Thank you very much.
much, ma'am, for such a wonderful performance, for such a wonderful session. Now I would like to invite Dr. Dwij Khullar sir. Topic for this session is full mouth rehabilitation, a peek into the future of dentistry.
Hello. Good evening, everyone. I am Dr. Divij Khullar, and firstly, I would like to thank Cynodent India for giving me the honor and the opportunity to share my views on full mouth rehabilitation with you all. Special thanks to Anmol ma'am and Ashish Chandra sir for giving me this opportunity. Now, full mouth rehabilitation is something that is a little difficult to condense in 20 odd minutes, but let's see what we can do in this and make the best of this time. So just a little something about me. I completed my post-graduation from Pavitra Dental College, Chennai, and currently I hold the world record for being the only postgraduate student to have done 54 full mouth rehabilitations during his post-graduation. Now, thank you. Now these cases were not just tooth supported but tooth tissue implants, full mouth implants, tooth implants, and over the course of these last 3 years, wherever I used to go for presentations, I felt that there is one thing that is lacking, one thing that everybody is very scared of, and that is full mouth rehabilitation in its own. So 20 minutes I can't teach you full mouth rehabilitation, but at least we can put the errors that we are doing to some light and then make sure that we don't commit the same mistakes. So just a little something about me more, that I also am a BPS specialist from Ivoclar, Switzerland. And now let's jump on to the main part of the presentation. So full mouth rehabilitation. Now the first question that comes to anybody's mind is that what, when and why. Like, when would we want to do it, why would we want to do it, and how would we want to do it. So before I begin my presentation, let me just give you a bit of statistics. Post-COVID, 1 in 3 people are either a bruxer or a clencher, and this is not just gender oriented, so it's both male and female that are doing it, and not just age as well. So there are young people even who are 20 years old having the same issue, and it goes all the way up till adults who are 50 or 60. And I am backed by a lot of scientific presentations that state the same, and these articles are all over the internet, because some or the other stress is just causing this to increase. Now, why is full mouth rehabilitation the future of dentistry? Because even if today you don't have cases that come to your clinic for full mouth rehabilitation, probably in the next 3 to 5 years you will be flooded with such cases. So you need to be well prepared, well in advance. So whenever a full mouth rehabilitation comes to your clinic, is that how you look at the patient? And is that the thought that comes to your head, that it's just going to rain money and nothing else now? But what if the cases that you are doing are just surviving for the next 3 to 4 years, and they come back again after again for repeats or some errors that you have done? So your aim as a prosthodontist or a general practitioner when you're doing a full mouth is not that to survive, but to make sure that it's successfully surviving. So the first common mistake that we do is that we as general practitioners or even prosthodontists, I would say, feel that a full mouth rehabilitation just means doing 28 teeth prep or the number of teeth and giving crowns on them. Now, how many of us think that full mouth is that? Can I just have some hands in the air? That just do some crown cutting and restore all of them with teeth. Appreciate the honesty, but that's exactly what we don't have to do. Now the second mistake, now I'll explain why over the next couple of slides, but the second mistake is that we underestimate the importance of our anterior teeth quite a lot. Now how many of us have heard or said the same thing to our patients, that आगे के दांत दिखाने के हैं और पीछे के दांत खाने के हैं? Can we have some more hands in the air? आगे के दांत दिखाने के और पीछे के खाने के. But my friends, that's the most wrong statement that you could have heard in the entire evening. Now let me explain why. Because your front 6 teeth, canine to canine, are not just for looks. They are not just for incising. They are not just for eating your favorite biscuit, but they are to protect your posterior teeth from breaking. And when you are doing a full mouth rehabilitation, you need to know how much width or height your posterior teeth need to have. So these teeth are the ones that govern it. And how do they do that? There is some mechanism called as anterior guidance, which states that whenever we move our mandible forward, like whenever I want you all to just protrude your mandible forward for a second. is glide your mandible in the forward direction. Whenever we protrude our mandible, only and only the tips of our lower anterior teeth glide over the upper centrals and laterals. And when we do that, all the other posterior teeth are completely disoccluded. And this is the mechanism that is present in all the individuals naturally, and this is something we want to mimic in our full mouths as well. Because when we do this, the posterior teeth are disoccluded, and that's how we protect our restorations from breakage. The other mechanism that we have is called as canine guidance, which means that whenever I take my mandible left or right, either directions, my mandible, only the canines are the ones in that direction that are touching, and all the other teeth are disoccluding. Does it make some sense to you all? Like, I want you all to just raise your hands in the air once. Now, tell me honestly that how do we eat? Do we eat like this? Or do we eat like this, like how cows eat? Is it like a crocodile that we eat, or is it like a cow? Cow? So how many of us honestly have given crowns and only checked some movement like this for a high point? I'm sure all of us. Have we ever checked for any other movements? So when we do this, how many of us have faced this issue that you have given a 3-unit PFM or a single crown also, and eventually the porcelain has fractured and the metal is exposed? Have you seen such cases? And it might have happened in one of the three, probably. Why is that? Have you ever thought, why is the porcelain chipping from just one crown? Because when you were giving the crown, you only checked for tap, tap, tap. Now this tap, tap, tap is called static. We have two types of occlusion. One is static and one is dynamic while we are chewing and eating. So we never settle the dynamic occlusion while we are checking for a crown, and that is the second biggest mistake that we do while we are committing to a full mouth. Now the third mistake, and by this I want you to know that you don't need to be a prosthodontist to take a Facebook record. How many of us have a Facebook at our center or our clinics? Or how many of us have recorded a Facebook ever? Okay. Do you feel that it's an important part while you're doing a full mouth rehabilitation? Is it? Okay, why is that? Okay, let's put some light to it. Is your maxilla a fixed part of your skull, or is it a movable part? Fixed part. And is it fixed in one parallel plane to the ground, or is there some angulation to it? So that's how our maxilla is. Most of the times, I would say 99% of the times, your maxilla is at an incline because it's the fixed part. Now when you are doing a normal mounting, now I'm sure all of us, BDS or MDS, whichever branch we specialize in, have done some mounting in our life. How? With a 3-point? How do we mount with a 3-point articulator? We pick up the wax from the floor, we make 3 blocks and put the cast on it, take the thread, and we just do the mounting. Am I correct? If we don't have the incisal pin, sometimes the matchstick that was there on the floor is used as an incisal pin as well. Am I correct? Now what is wrong when you do that? Observe. When you do a normal mounting, that's how your mounting comes up to be. Am I correct? But when you mount using a face bow, that's how your mounting looks like. Can you appreciate what I'm trying to say? It mimics the angle of your maxilla, and when you do that, you not only get the perfect smile arc that Dr. Neha Naveed was putting light on, but also at the same time that problem of your porcelain chipping from your posterior restorations is taken care of. So that's the third mistake that you do. You don't take a face bow record when you're doing a full mouth rehabilitation. Now just to put a little thought on this, face bow records are not only for just full mouths, but also when you're doing a smile design case or when you are doing a bilateral FPD like in this case. So this is somewhat like a face bow record looks like, and it's not a very tedious job. It's probably, if you've trained well, just 5 odd minutes, but it makes your job easy. Now let me stop here and ask you one other generic question. How many of us have faced this issue that the crowns that our lab gave were fitting perfectly on the articulator, but they were not fitting in the patient's mouth? Have you faced this issue that your crowns were sitting on the articulator beautifully, But when you place them in the patient's mouth, there is so much of open, and then you need to take it on your ego and we start trimming it till that crown fits. Have we faced this issue? That's again because we did not take a Facebook record, we did not do the mounting properly, and the crowns were made in a horizontal plane, whereas they had to be made at an incline. So these small mistakes where you spend probably an hour or two to correct it clinically, at that time if you just take a 5-minute Facebook record, these errors will be sorted. Now the fourth mistake, this is one question because I lecture about full mouth rehabilitation in a lot of platforms, and this is one question that is commonly asked to me, that doc, which articulator can I use for a for a full mouth? Now the most common articulator that we use is that mean value articulator. Now how many of us feel that it can be used after this brief interaction of 5 minutes for a full mouth? Anybody? Can we use a mean value articulator for our full mouth rehabilitations? We cannot use a mean value articulator, but can we use these articulators that your local labs have? What is this? Have you seen this articulator on the left? Have you seen the one in the middle? These are not even mean value articulators, they are just some articulators. Can you use this for a full mouth? You cannot use any of these for a full mouth because of two basic main reasons. One, because they don't allow for a phasebow transfer, like I just explained that it's so important. And the second, now this is a little bit much of prosthetic, so I'll just give you a very brief of this. You cannot record or change the condylar guidances. Now I can't explain that in 5 minutes, but that is something that you need to do while you're doing a full mouth. So you need to use either a semi-adjustable or a fully adjustable articulator. Now the fifth mistake that we commonly do. How many of us, before I jump into this, let's just understand how many of us understand this concept of maximum intercuspation and understand this concept of centric relation. Can we have our hands up in the air, please? Or are they both the same? Are they both the same? Is there some difference? What is the difference? Have you encountered a bruxer or a clencher in your clinic with flattened teeth ever? Practitioners here? Now whenever you have worn out teeth, you forget the maximum way that you were intercusping before, and your muscles tend to rest and they come either in a forward movement or you have a deep bite. Have you experienced this, that if there is flattening of teeth, what will happen to the bite? It will go down, it will go deep. If there is a bruxer, he will completely lose all intercuspation and his mandible will move forward and you will have something which is called an edge-to-edge bite. So this current bite that is there, that the patient has, is called his maximum intercuspation. That is, how is he biting at this instance. But does that mean that is that his centric relation? What is the centric in a complete denture? Anybody? Let me break it down easily. We have all made complete dentures before. Anybody who has not made a complete denture ever? How many of us have seen these patients who turn into habitual class 3s? What's a habitual class 3? That when he has no teeth, he moves his mandible forward, something like this, and the minute you give him a complete denture, it slides back into a normal motion. Now this normal place where the patient's muscles are at rest is something which is called as a centric relation. So when you do a full mouth rehabilitation, you have to do it in a centric relation and not in a maximum intercuspation. Now a very brief of this, how do you do that? So there is this concept of deprogramming. Let me break it down easily to you. Suppose you've gone to the gym and you have taken some weights and you have lifted them. How many of us gym here? Can we have hands? Is it possible for you to hold on to that weight for the whole day? Even if it's a 1 kg weight, the minute you lift it, there is some amount of pressure that happens to your muscles and then eventually you have to drop it to come back to rest. So deprogramming is something similar, which makes sure that your patient's muscles are at rest so that before you do a full mouth, you have his musculature at rest so that your crowns last longer. This is what a deprogrammer looks like. This is one kind of an anterior deprogrammer. There are multiple such where there are short, intermediate and long ones. This is something which is like an intermediate one. The main aim is to just drop that weight. And how do you do that? You put something in the middle so that your maxilla and mandible are apart and the muscles are now at rest. Now this, I want everybody to wake up, focus, because this is going to change the way you look at dentistry for the rest of your life. How many of us have done a case where we have raised the vertical dimension? Can I have some hands in the air? Any case where you have raised the VD? Any denture case where you might have played around with the articulator to raise something up and down? So have you raised the VD of any patient before in your clinic? What is the most common thing that we do? I'm sure senior practitioners here would have done some cases where you have raised the vertical dimension. So what's the most common thing that we do to raise the VD? What is the most common? Anybody? Have you seen this thing on the articulator? What is this thing called? Have you seen a line, a metal rod in the center of your articulator before? No, not the incisal pin. The incisal pin is the one that you replaced with the matchbox or the matchstick. There is something in the middle, that long slender thing. Incisal rods, come on. Have you seen this before in an article? Have you ever mounted before? So the thing that is there in the middle is called the incisal rod. So does it have these indentations or these markings there? It does. What is the easiest thing to do to raise the vertical dimension? Just open it and raise it 1, 1, 1. Is that how we do it commonly? Are we Prosto postgraduate students there at the back? So every incisal pin that you have or the incisal rod has these markings. There is a red in the middle which is 0. There is 5 on the top and 5 in the bottom. So what you do is, we usually open the articulating pin, raise it to 1, 1 level, thinking that that's raising my vertical dimension by 1, 1 mm. So when you do a full mouth rehabilitation, the maximum that you can raise your VD is by 5 millimeters. Now does that mean I open my articulator and I open this pin and I just raise it from that red all the way till up 5? Does it mean that I can do that? Is it the correct way to do that? Anybody? Let me explain what happens when you do something like that, so that even if you're not doing it now, tomorrow you don't make that same mistake. So like I had explained, our maxilla is at an incline. So that means our mandible is at an incline as well. Common sense, if the maxilla is at an incline, the mandible is too at an incline, which means that the anterior area, when you open your mouth, opens a bit more and the posterior opens a little less. I want you all to just open your mouth a bit. Everybody. Is your anterior space more or is it the same in upper and lower both? Anteriorly you open a bit more. Now I want you all to yawn as if this is a very boring lecture. Everybody just open your mouth big and yawn. I hope they don't get this on camera. So when you yawn, is your mandible moving a little back while you do that? When you open your mouth quite a lot, is there a backward motion of the mandible that happens? So let's understand what I'm trying to explain. If you arbitrarily just open this pin and raise your bite say by 3 millimeters, you are only raising your anterior bite on the articulator by 2 millimeters and posteriorly you are just raising it by 1 on the articulator. That's why when you make these crowns, they sit perfectly on the articulator but not in the patient's mouth. So how do you correctly do it? Let's put some height to this. Let's understand with the help of this one basic thing. So this, everybody on the screen, is an articulator and that pin that is there in the middle is the incisal pin I'm talking about. Now it makes sense? So all you have sometimes do is just open this black thing at the top and raise this pin up and down to raise the bite by 1, 2, 3, 4 or how much ever you want. Now when you do that, let's see what happens. Now understand this with the help of this animation. I want you all to just look here. Now this is a case where you have raised the bite by 1 millimeter. Okay, before we do that, let's understand very normally. When I talk about bite raise, what comes to your mind the first thing? Do you want to raise the bite with the way your posteriors are disoccluding, or do you want to do it anterior way? By raising the VD, do we want to get more space in the posteriors? That's normally what we feel. But let's understand what we are doing. When we are raising arbitrarily on the articulator, say 1 mm, observe your anterior teeth and posterior teeth have some amount of disocclusion. Look there very closely. Now let's assume you are not happy with the bite raise. So you ask your lab guy to just raise it by another mm, which is 2 millimeters. A little more space. But then again, I'm not happy. I don't want my lab to get back to me saying that you didn't have enough clearance. So I ask them to raise it by another 1 millimeter. Still not happy. I ask them to raise by another millimeter. Ample space in the back, but is something happening to my anterior teeth as well? Is something happening? You want to see, have a look at this again. Now assume this is at 1 millimeter, at 2, at 3, at 4, and now at 5. I'm getting more space at the back, but my mandible moves backwards, so there is a lot more space in between my upper and lower central incisor as well. Does it make sense? No? Okay, let's understand once again. When you raise your bite, say just by 1 millimeter on the articulator, this is your scenario there. You do it again by just arbitrarily raising it by 2 mm. You get a little more space at the back, but your mandibular incisors start to drift back, because when you open your jaw, your mandible starts to go back. 3 mm again goes a little back, 4 another little, and then 5, yes, you go back furthermore. So this is not how you raise your bite. The biggest mistake when people do while they are trying to raise their VD is they do this. How do you do it the correct way? You deprogram the muscles, and that's the way you get your bite to perfection using a different method, which is not this. You always look at the VD raised by your anterior teeth, that how much space is there in my anterior teeth to get the overjet and the overbite corrected. What's overjet and overbite? Overjets basically my upper and lower teeth, central incisors need to have about 2 mm space, and overbites again my upper teeth just need to glide them by 2 mm. When I arbitrarily raise my bite, say again to 5 mm, can I get a perfect overjet overbite here in this scenario? I hope it starts making some sense. So you can't just raise your VD arbitrarily. So that's the biggest mistake that we do while we're doing a full mouth. So the next mistake is, and this comes even for single crowns. How many of us still believe that we have to do an intentional RCT when we are crowning a tooth? Can we have our hands up in the air? Every time I give a crown, I need to do a root canal. Why is that? Especially when you're doing a full mouth rehabilitation, you are talking about crowning 28 or 26 teeth. You don't do intentional root canals, because no matter how well your root canal is done, it makes the tooth brittle, and eventually after say 10 or 15 years the tooth breaks. Then what do you do? So you only do a root canal in a full mouth rehabilitation if you have exposed the tooth while you are prepping, or the patient is extremely sensitive in that one particular tooth. That doesn't mean you leave it like that. You use desensitizing agents while after you have prepped and in between your phase when you are giving temporaries. Now these desensitizing agents put a coat on the tooth, and they make sure that the dental tubules are sealed temporarily and the patient does not have sensitivity in that time before you have placed the final crowns. So never do intentional root canal treatment for all teeth on all 26 or 28 teeth. Now the 8th mistake that I had put some light on earlier was that how many of us, like we have discussed, have used this one articulating paper, or most of the times carbon paper as we do in our country, and we just ask the patient to tap, 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 and we check that whatever high point is there, we remove it, not knowing where to settle, what to settle, and we send the patient off. But we forget that that's not how the patient eats. The patient eats like a cow. We eat like a cow. So you not only have to settle the static occlusion, but also the dynamic occlusion while you are doing a full mouth rehabilitation, because that will make sure that your crowns are not chipping, the porcelain is not chipping, the zirconia is not breaking. So this is what I mean by static occlusion. Tap, tap, tap. and on your right is the dynamic occlusion where you move your mandible in laterotrusive and protrusive manners. The last thing that I would say that whenever you do a full mouth rehabilitation, you haven't changed the bruxer or the clencher. You haven't cured the patient psychologically. You are a dentist at the end of the day. He'll still be a bruxer, he'll still be a clencher, so you need to protect the crowns that you have given, because like he broke his natural teeth, he will also break his crowns. So you do something which is called as a splint therapy. The splinting can be done different ways. The most common ones an anterior repositioning splint that you give your patients to protect the crowns that you have now given and make sure that your full mouth lasts as long as it can. A very difficult topic to speak on in 20 minutes, but I hope you've taken at least 1 or 2 points back, at least taken some points that you were doing the wrong way, and I hope to see you soon to understand the right way of it. Let's just take another 5-10 odd minutes to put some cases out there so that you understand the treatment planning a bit more. Now this case that I will show you first is one of the dearest cases to me. I did this case when I was in my second year of post-graduation. Now this gentleman is 21 years old, and when he had walked to us at the age of 21, he had walked to us like this. That's his front, that's his left, and that's his 45-degree. When he had gone before us to multiple dentists, rightly so, most of them said that we cannot give you crowns, we cannot put implants, you need to extract these teeth, whatever are remaining in the maxilla, and wear a complete denture at the age of 21. Now answer honestly, if something like this has to happen to you, would you wear a complete denture at 21 for the rest of your life? Would we? So then this patient happened to come to our clinic or our center at Savita, where we decided to do something different for him. Now before I say this, I want you to all understand one thing, that full mouth rehabilitation does not mean that you are a prosthodontist only that can do it well. Whenever you do a full mouth case, you need to look at all 8 branches that you have learned, be it perio, be it endo, be it prostho, be it ortho. Every clinical branch needs to be looked at so that you can get the best possible result. So in this case, if I would have just looked at it like a prosthodontist, probably I would have also said that let's just remove these teeth because they're not good enough for crowning or implants, let's just give a complete denture. This is how he had walked to us intraorally on day 1. So he had something which we call as a skeletal class 3, as we can see the mandibles protruded quite a lot, because of which his upper teeth were completely worn out. So if I would have just looked at it like a prosthodontist, like I explained, that would have been the treatment planning. But then I thought again and again, and we looked at it as a general dentist, and we decided to do something called a bilateral sagittal split. So we decided to do an orthognathic surgery for this patient. What is a bilateral sagittal split, anybody? BSSO is basically when you cut the mandible in 2 segments and take it back and you stitch it back so that you get the correction done. Something that we need to do when we have a surgical class 3 case. So I'll just run you by the pre-surgical workflow. Before that, this is the pre-operative maxilla and the pre-operative mandible right there in front of you. Correcting it in this particular bite would have been a disaster because whatever we did would fail. So in this case, the OPG was something like that, and the lateral ceph can show you how much the mandible was in a forward direction. So this is the pre-surgical workflow. We mounted the case using a face bow. We did a mock surgery on the articulator, on a fully adjustable articulator. We made a splint after the mock surgery was done, so that guided us when we were doing the BSSO on the table to place the mandible in the exact position and stitch it back. Once the pre-surgical aspect was done, the same happened in the surgical part, and then once that healed, this is how he was just after surgery. So can you explain, can you just see that how much of teeth are now visible? How much of better options can we now do? Now the first thought that would come to anybody's mind would let's just take these teeth out and place implants. But at the age of 21, the best implant as a prosthodontist that I place would also last only till 40, best to best 45. Then again at 45, all he has to do is remove and wear a complete denture. So how about we give him 10 odd years of fixed crowns till say 30, 31. Another 20 by implants. They start to slowly fade away and fail. We convert that to a removable. And at the age of 60, 65, we finally give him a complete denture. Makes more sense? So we did something in the mandible which just required some amount of restorative care, just some amount of class 3s. The maxilla, on the other hand, was where we had to work a lot on. So we did cast posts in the maxilla. In some teeth we just did fiber reinforced posts, did a good prep, took a mass impression using 3-shape, designed the temporaries as well as the finals. Did a good coping trial. The OPG at the stage of coping trial was this. Can you see these two metal plates in the mandible? That's post BSS, so to stabilize the mandible at the back. In the end, this is the centric that I could achieve. This case lasted for probably about 8-9 months, but I think they were worth it. Now let's just look at the difference in the smile that I could create by just thinking and looking at this case as a general dentist. The front profile, the side profile. Can you see the mandible go back? Thank you. And if you want to see a close-up of the same, something like this. Now we are short on time here, so I'd just like to show you one last case, which is also a challenging full mouth that I have just done. Another case that would require surgical aspect, but let's be honest, how many patients would opt for a surgery when they come to your clinic? Not everyone, so let's understand how do we manage such cases without a surgical aspect. Because showing simple full mouth cases is very easy, everybody can do that. So let's see here. This is a case of a lady who is 60 or 62, if I remember correctly. She had the similar thing but in a different direction. Can you observe the gummy smile? Can you see from the side profile the amount of maxilla that is there in the front? So this is a simple case of the mandible going back and a maxilla coming out a bit. Easy would be to just do surgery, get the maxilla in shape, probably do a bit of lip repositioning and get this. But 62 years, didn't want to go under the blade. So we just had very minimum scope to work on. This was her when she came to us on day 1. That's the closed bite. Can you observe no amount of teeth visibility in the lowers? That's just to show you a bit of opening. Now, if you just look at the top case, would you think that like I explained to you, that 5 mm is the maximum we can raise? Would you just want to raise the bite by 5 mm in this case? Let's get the maximum amount of bite raised. Would we still want to do that? Wouldn't our maxilla, which is already in front, and the mandible, which is already at back, go further back if I raise just by 5 mm? Is it making sense? So then, doing the right bite raise by the method that we do, we came to a conclusion that this case can only be raised up to 3 millimeters because the mandible was going way behind and we were losing the overjet and overbite, and hence causing a lot of phonetics and aesthetic problems. So this is what we could achieve post the full mouth. And if you want to look at an open view, this is how it was post the full mouth. Now there's a slight bit of catch here. Now there I worked as an orthodontist as well. Now here I want to explain that we took a bit of perio on board and did something which is in the front 4 teeth. Can you appreciate what that is? Crown lengthening. So when we do some amount of crown lengthening with lasers which are minimally invasive, the patient's on board with us, and let's just see how much of a difference can it make clinically by just looking at it the other way. That's what I could achieve. No lip repositioning, no surgery, just a bit of crown lengthening. The crowns look a bit longer and they still look natural and fine. Thank you. Now, if you want to just see the side profile, which is, I feel, even better, that's what we could achieve just by doing a bit of crown lengthening. So, full mouth rehabilitation is not that difficult. It's just that we don't know sometimes what we are doing. And if we just get the basics correct and the mistakes are out of the picture, we are all, I'm sure, able to achieve results like these. So with that, I would like to conclude my presentation and also thank the organizers once again for giving me this opportunity. And I hope to see you all soon someday. I conduct these courses on full mouth and complete dentures. So I hope I can see you and teach you sometime later in the future. Thank you. that's my Instagram page. I come by the name of Dr. Divij Kullar. So if anybody wants to interact, that's my handle right there. Thank you.
Thank you so much, sir, for such a wonderful session. Now, I would like to invite Dr. Anmol Bagaria, ma'am, Dr. Ashish Chandra, sir, Dr. Pankaj Patel, sir, Dr. Ruchi Patel, ma'am, for felicitation. I would request Dr. Ashish Chandra sir, Dr. Anmol Bagaria ma'am and Dr. Pankaj Patel sir to felicitate Dr. Ruchi Patel ma'am. Thank you ma'am. I would like to invite Dr. Vishwaraj Nikam sir for felicitation. Thank you, sir. I would like to invite Dr. Krishna Prasad, sir, for Thank you, sir. I would like to invite Dr. Neelam Das, ma'am, for felicitation. Thank you, ma'am. Now, I would like to invite Dr. Bhuvan Nagpal, sir, for felicitation. Thank you, sir. Thank you, ma'am. Lectures. I would like to invite Dr. Vishwaraj Nikam, sir. He is a eminent oral and maxillofacial surgeon.
Good evening all. This beautiful city, historical place, Lucknow. Myself is Dr. Vishwaraj Nikam, oral maxillofacial surgeon, working in Pune, Maharashtra. And I'm very happy to see you here. Patients listening, you are still sitting in front of us. And this is the one of the good opportunity to learn. Because of this, Lucknow is very hot. Atmosphere is very hot. And even my topic is also very hot. This is minimal invasive procedure for mandible impacted third molar tooth. A study to prevent incision and soft tissue handling. It is something new, something different. See, in 40-50 years back, abdominal surgeries were like this. Open abdomen surgeries or any pathy, any surgeries were not minimal invasive. But the demand of the stitchless or minimal invasive surgery is increasing day by day in all pathies. Patient का demand होता है, कितने टाके पड़ेंगे? Because patient count, patient ऐसा count करता है कि कितने टाके पड़ेंगे उसके ऊपर the surgery और उसका डर. So after 20 years of practice, right now I am practicing since 21 years, but after 15 years of practice, I realize after the extraction of thousands of third molar, something should be there like minimal invasive procedure in case of mandible impacted third molar. I don't want to discuss the initial protocol, you know all. And for my technique, I got copyright by Government of India in 2019. Felicitated by Dr. Christopher Hemmel, University of Switzerland. I don't want to discuss initial protocol. You know all better. I'll directly tell you what is MIP-MIT, minimal invasive. You can Google it and see the whole article also whenever you get free. See, in our language I am telling you, what is the motto or aim behind the third molar removal? We have to remove all the resistances. Am I right or wrong? The first main resistance is the adjacent tooth. Because all 80% cases are hidden below the cervical C junction of the second molar. So, first of all, what I do trimming of the contact point by trimming the third molar without hampering second molar. If even it is visible 5-7% in the oral cavity also. I'll show you case by case, right? Now, after removing the contact point, there are 2 points during removal of third molar or any third tooth. You have to study 2P, 1, purchase point and path of removal. Believe me, I'm telling you everything out of the book. Every tooth should have its, you have to get one good purchase point and path of removal. Path of removal you have to study here first. It is like a wrestling. हर बार ताकत की जरूरत नहीं होती है कुश्ती में. उसमें भी डाव होते हैं. तो extraction में भी डाव होते हैं. So what I mean to say you, every tooth is having its own path of removal. So you have to study it first, the path of removal. Simple things I am telling you. You have to trim the resistance first. If you are not confident, use matrix band in your early initial days. After cutting the contact point, create a purchase point. If it is there, it's okay. It's not, trim slightly, undermine the tissue and slightly trim that bone, just one ditch and get a purchase point. I am telling you, never ever use air rotor in the tissues. It may cause surgical emphysema. Contact point you may break with the air rotor, but purchase point or gutter of the distal bone, even no see, what is the main culprit behind the post-operative complications of third molar removal? Anybody student from backside? What is the main culprit? Don't know. Soft tissue handling. If the soft tissue handling is less, the post-operative complications are less. So, without raising or incising the tissue, you have to reflect the gums and just undermine the collar of the distobuccal area with the help of help of micromotor with copious irrigation. And what will going to happen for that? After that, this is okay, but the main concept of my MIP-MIT is whenever you are elevating, always we elevate from the mesial side and elevating distally like this, right? But there is external oblique ridge and anterior body of ramus, very thick, huge bone. There is a big repulsion from backside. Believe me, whenever you remove 6 lower first molar or any tooth, where you pull buccally or lingually, buccally. तो सारे दांतों का, सारे टूथ का पाथ ऑफ रिमूवल इज बक्कली. तो ये भाई साहब ने क्या किया है? इनका भी पाथ ऑफ रिमूवल बक्कली है, but it is unable to pull because of that tooth is hidden inside. I am not able to pull it buccally, at least I can pull it buccodistally. See, if I am cutting the contact point, my elevator is going more in, so I am elevating like this, but now I am elevating like this. And it becomes a cornucopia. Cornucopia, Google it, it's a physics. I love physics a lot. In even 12th, I had 100 out of 100 in physics. Physics is a physiology of nature. Extraction में physics काम करता है, याद रखो. तो ये चीज बहुत important है. Whenever you elevating distobuccally, what is cornucopia? Cornucopia is a spiral. Cyclone आता है, कैसे आता है? Every quarter turn it becomes wider, right or wrong? So tooth moves like this, and that is a cornucopia. It's a nature's law. Sunflower, it's a cornucopia. Galaxy, it's a cornucopia. Key point of extraction नहीं लेता हूँ मैं थोड़ा. This is my first case. Believe me, Can you imagine this tooth with stitchless or minimal invasive procedure? And if the X-ray is like this, see the tooth is out, toto, like a simple extraction, patient satisfaction and healing after 7 days. Another, see the cornucopia. This is cornucopia. In geometry, a golden spiral is a logarithmic spiral whose growth factor is phi and the golden ratio. That is, the golden spiral gets wider by a factor phi for every quarter turn. It's a cornucopia. Every structure, including maxilla, mandible, teeth, etc., had growth site and growth centers. Growth centers, from the growth center, the tooth develops in a path which follows the logarithmic spiral. Logarithmic spiral follows the golden proportion like emerging as a cornucopia. Scientist Robert Murray Ricketts had studied growth rotation in detail and gave the theory to determine the center of a rotation of a mandible, from which we can access growth of a mandible, that is a growth prediction. Similar theory applied on the third molar growth centers, then the growth of a tooth is occurring in a logarithmic spiral path and also follows the golden proportion, so that in MIT, patient position, doctor's position, instruments, purchase point, site and force directed into the distal-buccal direction, expansion of a cortical plate, all will provide same rotating or spiral direction to a tooth in which tooth develops naturally. So MIT actually following the tooth eruption pathway, and hence it becomes absolutely less traumatic. This is a mechanico-physiological theory of MIT. See another case. मैं थोड़ा rush कर रहा हूँ because you have to see some cases. See another cases, because this is a topic of at least 1 hour, but it's okay. See, if the 7 is carious, no need to take care. In case of distoangular, now see, distoangular mein we have to elevate the tooth from distally, because tooth is like this, we have to make it straight and take it out. But if you are breaking the contact point, and in this condition, if you are applying the elevator distally, the contact point, the surface area in connection with both tooth are less now, the resistance from the second molar is less, that lowermost point acts as a fulcrum, tooth rotates around its own axis, and it is easy to take a position, make it straight, and it will come out easily. And this is distoangular is also out. This is another case. For example, everywhere in the world, Germany, Japan, Korea, India, Delhi, Kolkata, Lucknow, everywhere, everybody is incising such tissue. Out like a collar. See, because if I am cutting the tissue, it belongs to the patient. If I am cutting the bone, it belongs to the patient. Good surgeon duty is that he has to preserve the thing that belongs to the patient. I am cutting the tooth that has to be extracted, and that is a best product for the patient. Now some huge rooted tooth out. See another case. See, the tooth is like this. See amount of time. I am going distobuccally. See, distobuccally. This is my favorite instrument. We call it as a Bhavani Talwar to this. This is a London hospital pattern. एक भवानी तलवार है और एक भाला है हमारे साथ, बस. He is a gynecologist. Tooth is out, toto, with minimal invasion. Now, J hook. See, the tooth is out. If the case is like this, see, everywhere there is only a simple flap. Why to incise the tissue? Tell me. This is like a normal delivery. I don't want to go for the caesarean section like a gynecologist. I am trying like a baby, the gynecology, the tooth is coming out. I have to struggle for that. Just undermine the tissue. You won't get post-operative complications. And why to show the patient that I am doing very big job and so you have to pay me? Don't tell like that. Tell the patient directly, this is my technique, this is my study, and I am making you free in 2 to 5 minutes, 7 minutes. It's minimal invasion, pay more. Yes, patient agreed for that. Because we should be ethical. Don't tell, don't make a show for just we are putting so many instruments and all like this. See, our Bhavani Talwar is so great and it's coming out. See my struggle. क्यों भाई क्यों आएगा इस पेशेंट को स्वेलिंग क्यों आएगा? हाँ, now if the case is like this, tooth is not visible in the oral cavity and the patient is having a chubby cheeks like this. Even the tooth is erupted and patient is opening the mouth, the fat is on the occlusal table of the tooth. We have to search tooth first of all, if even it is erupted, and if the X-ray is like this, then can you think for the minimal invasive or without incision? And see the tooth is out. See the invasion, no patients complain, nothing. If the case is like this, cut the contact point properly. Tooth is out. Patient is happy. This is after extraction, not before extraction. Sometime before extraction is also, the photo is like this. Now see this case. Ashish sir, 5-7 minutes more. Thank you. See the another case, because this is very important topic and we have to, because अभी तो मैंने बहुत सारी cities में 6 countries में introduce किया है. You can see me on Google. And ये मेरा मानना है, पता नहीं, but within 4 years patient will ask you in your clinic, इतना मैंने वो spread किया है कि आपके यहाँ पे बिना टाके की अक्कल दाढ़ निकाली जाती है या नहीं. The demand of the stitchless is very more now. See the case and see the tooth is like this. Can you imagine? See the tooth is like this. And we are surgeons. Surgeons must have 3 qualities: lion's heart, lady fingers, and eagle's eyes. And eagle's eyes should be on the tip of your fingers, because आपके उंगलियां ही आपको बताती है what is happening. हम क्या करते हैं? एक तो कुछ एक्सेस नहीं होता है, टिश्यू वहीं पे, ब्लीडिंग, टंग, इंस्ट्रूमेंट, सक्शन, एवरीथिंग, कटिंग बर, हमको ही कुछ नहीं दिखता है, फिर भी हम चिल्लाते हैं असिस्टेंट की तरफ, उसको तो इतनी सी जगह दी जाती है, ठीक से पकड़ो, दिखता नहीं क्या? तो मैं बोलता हूँ ये करने की जरूरत नहीं है. See and go follow this. But I am telling you once again, ad आती है, don't try this at home. Like that, I am telling you, don't try this at your clinic until you get a good knowledge, good that sensations of the, otherwise mandible fracture may happen. You have to learn first of all these things nicely. See the patient's satisfaction in this. There is a cause in the oral cavity. See another case. if the tooth is like this, out, see the invasion, see even bone भी कितना hamper नहीं हुआ है. These are my, one is Bhavani Talwar and one is Bhala, my favorite instruments. और शायद ये दो कोई नहीं use करते. We want a fancy instruments. No, old is gold always. This is my clinic. This is another case of huge roots. Tooth is out. Once you get that physics in your mind, the cornucopia, believe me, you will remove every tooth like this within some minutes. If now you will ask me, sir, पता नहीं आप करते हो, बाकी लोग कैसे करेंगे, हम कैसे करेंगे? See, I conduct courses every month. 3 people are coming worldwide here from India to my place for 1 month, and see the girl from Mumbai. See another case. अभी इसका ये मैं नहीं दूंगा आपको, इतना टाइम नहीं है अपने पास. हाँ, see, done by that girl. See, after proper learning, see the minimal invasion everywhere. See the minimal invasion. See the tooth where it is in the X-ray. See, minimal invasion. Lot of thousands of cases. The girl from Dubai came for the course. See the pattern of root. Still the minimal invasion done by that girl. Thousands of cases are there. Even foreigners are coming from so many places. Bilateral, same time. See, she's from US, same time bilateral horizontal. Voice please. First, I presented this topic in the one Maharashtra State Conference. Then I conduct courses for this at Pune. First launch in national conference. Then this, you won't believe, out of 50 people turned for the course among this. In Mumbai, got national prize at Trivandrum, Kerala, Uzbekistan. And the most important thing is I presented this technique in the conference of oral and maxillofacial surgeons at Maharashtra State Conference. Again, one more thing, I presented this in oral and maxillofacial surgeons of national conference. And again, 1 month back only, I presented this in 16th Asian oral and maxillofacial surgeons of Asia countries. So this was live demo in Ahmedabad Dental College. Within 3 minutes, 4 minutes, 7 extra third molars done. This is my Raipur course. We teach everything from basic. Another course is in Raipur only, same place. 2 days course is there. This is copyright from IDA, Kolam Trivandrum, by World Dental Federation appreciated. This was Pune, and I got a Family Dentistry Award of the year 2022. And actually, believe me, now listen this is very important. Means in Mumbai, people are conscious now for this. What the sir is telling, just listen to this. Voice please. And the most important thing for me is appreciated by Dr. Stanley Malamet sir. And this is my copyright. Not only copyright, this is with my trademark, and this is going to come in the textbook of oral surgery, MIT Dr. V.H. Nikam's technique. Apart from medical field, I love to work in TV serials. I played a role of Chhatrapati Shivaji Maharaj in Mumbai. You can contact me, feel free to contact me on this, my number, or anybody want to join the course, or anybody want to, I am very freely available person. I never miss my call. Only I am in a lecture, otherwise, if even students I am telling you, if you want to ask, start with the conical roots, simple roots, mesioangular, do it, and एक बार आपको वो कला आ गई तो उसके बाद in your city patient will tell to each other that यहाँ इनके यहाँ पे बिना टाके की surgery होती है. So this is very important. This sentence is very important. The perpetual preservation of what remains is most important than the meticulous replacement of what is lost. Divan's principle. Thank you very much. Jai Hind. Thank you. विनती करना चाहता हूँ, जो हादसा हुआ है कोलकाता में, उसके लिए हम एक अपने या इसकी वजह से एक मिनट उनके लिए हम खड़े रहेंगे थोड़ा सा. Anybody want to ask anything? I am available outside, because next lectures are important. It's already late.
Thank you so much, sir, for such an informative lecture. Now I would like to invite Dr. Piyush Shivhare, sir. Topic for this session is muscular pain in orofacial region.
Nice presentation. That's a new technique, and I appreciate that technique. And we should work for new techniques, and that is minimally invasive techniques. Although work are going on all AI techniques and very costly techniques, which is I don't know how much is possible in India, but such techniques should be appreciated, and we should work for more for that. And my topic is going to be very basic topic. Okay, it is not a very the difficult one, or it's a newer one, but a basic topic and very frequent topic of having patient with muscular pain encountered in our daily clinical practice. So this is something about me. I have fellowship in orofacial pain, TMDs. So the muscular pain is I'm very much interested in muscular pain, so I will be presenting that only. Currently I am working as associate professor in Government Medical College, Chandoli. Okay, usually lots of patient reported to our clinic with patient either complaining of, doctor, I am not able to chew, okay, not able to open my mouth completely, not able to yawn, feeling pain in teeth irrespective of no dental pathologies. When you check your odontogenic causes, there is no specific dental pathology, there is no decay, there is no tender on percussion, but still patient feels there is a pain in teeth. Pain in TMJ region, although there is no radiological finding, there is no features of any arthritic changes. Pain in ear without no ear pathologies. Lots of patient comes with patient complaining of pain in ear, and you referred a patient to ENTs, then ENT referred back again saying that there is no specific ear pathologies. Feeling of tingling sensation, not getting proper sleep, or many the patient have visited to many clinicians like ENT, dentist. So what we does for this patient? Okay, we either restrict ourselves to the evaluation of third molars. We say, okay, third molar is not getting erupted or it's partially erupted, maybe this is the cause for the pain, or sometimes we directly jump to the muscular pain. We give muscle relaxant, painkillers, all physiotherapy, still patient is not getting relief. So why this is so? Either because of incomplete examination or wrong diagnosis. So my topic is going to be myofascial pain dysfunction syndrome. Remember that it is not myofascial, it is myofascial. Okay, so lots of when I used to correct a BDS paper, they used to write myofascial. It's not myofascial, it's myofascial. So the main culprit of myofascial pain dysfunction syndrome is called as trigger points. It's nothing but it's a hypersensitive bands of, it's called as taut bands. So we can see these, sorry. So these are the muscle fibers, and after the prolonged microtrauma or macrotraumas, some of the fibers get be contracted, and it will be a taut bands, and which will be more tender. So this is called as trigger points. So what are the precipitating factors? So precipitating factors, it can be a trauma to the muscles, occlusal disharmonies, chewing hard food, chewing gums, opening mouth wide for a longer time, systemic factors like emotional stresses, vitamin D deficiencies, sleep disturbances, systemic factors. Out of these, which I used to see is one of my articles we have done in Nepal, and we have seen that the hard food biting habit was one of the most important culprit other than stress and occlusal disharmony. So our food habit is also important for such cases. Stress is very important. We have to ask history about stress always, about the emotional stress, about the sleep, because once if there is a stress, there can be altered muscle tensions, reduced circulations, followed by muscles pain, and that vicious cycle again will be going on. So this is one of the case, the patient of nearly 18 years old patient reported with severe pain in the masseter muscles along with temporalis, and lots of treatment have been done with the patient, but still patient was not getting relief. So we have asked we have asked about the menstrual irregularities, and there was menstrual irregularities was present, and we have asked the ultrasound, and there was a right ovarian cyst. So sometimes such systemic irregularities also can cause muscular pain. And even in the articles, it clearly mentioned that the ovarian cyst and ovarian dystrophies can be related to fibromyalgia or the muscular pain. So these are the very important systemic evaluation which we should not miss. Now pathogenesis is, we all have seen the pathophysiology behind or physiology behind the muscles contraction and muscle relaxation, and we know the calcium and ADP is very important ATP is very important for muscle contraction and relaxation. So following the microtrauma and macrotrauma, there will be depletion of calcium and ATPs, and that will lead to formation of firm taut bands and contractions bands. That will reduces the further blood supply, releases of endogenous inflammatory mediators, and that will cause pain. That is the pain in the triggered points. So what is Laskin criteria? We are all have seen Laskin criteria in the final year exams, very routinely asked question. So there will be 4 positive cardinal signs, that is pain, pain in the muscles, muscular tenderness, clicking and popping sound, limitations in jaw movement, and there will be 2 negative features, like there will not be any clinical or radiological features. Now then how you will going to diagnose these cases? First is you have to palpate trigger points. That is the most important thing. When you palpate trigger points, there will be a twitch response and patient will jump. So that is called as twitch response or the jump sign, and that is most important features. We should able to differentiate trigger points and trigger zone. Now trigger zone is seen in trigeminal neuralgia, where you just touch the tissues and there will be pain. But in trigger points you have to palpate it, you have to apply pressure. So you have to palpate, you should know how to palpate, because it will be a firm nodular type of feelings. You will you have to palpate this, make sure that it's a trigger point, nothing else. Okay, one of the important feature of MPDS is the referring pattern. We all know that the fibers of the orofacial structures along with the neck and or the tooth, they all converge into pons and medulla. So if there is a pain in the muscle structures like temporalis muscles, it can refer to the odontogenic region, or the odontogenic pain can refer to the neck or the other muscular structures. Similarly, MPDS also have referring pattern. So sometimes the pain in the anterior temporalis can have a pain referred to the anterior tooth, or middle temporalis to the premolars, or similarly posterior to the posterior tooth, upper posterior tooth. So this is the thing why patient is complaining of pain in tooth. Still you are checking the odontogenic cause. There is no specific odontogenic cause, and you missed the palpation of muscles, the examination of muscles. You are giving all treatment for the odontogenic cause. Still patient is not getting relief. So check the muscles also. Similarly, there is a referring pattern of the masseter muscles, the SCM. So how you are going to check properly about the referring pattern? So if you palpate the site of pain, okay, if you provocate the source of pain, there will be the sensitization of pain along with the muscles along with the tooth as well. But if you revert back, if you check, if you do the tender on percussion for the tooth, there will not be any pain to the muscles. Remember that. So the site of pain should be palpated properly. Similarly, if you inject local anesthetic for the muscles, there will be the complete relief of pain. But if you do the anesthetic injections for the tooth, there will not be any relief of pain. So this is how you have to diagnose, you have to check. Associated symptoms like tingling sensation, numbness, vertigo, blurred visions, fatigueness, these are all features can be present with MPDS. So how to diagnose these cases? Because there is no radiological findings, no investigatory findings. It's the proper history, examination of muscles or trigger points, proper history of sleep, stress, you have to rule out odontogenic cause. That is the most important thing. Now what is soft end feel and hard end feel? So patients have a restricted mouth opening, but patient is still able to open her mouth after applying pressure. And now patient having pain. Patient is showing that patient have a pain in the masseter muscles. So that means it is called a soft end feel. That is a feature of MPDS. Now what about hard end feel? Now this patient also have restricted mouth opening. Now we are applying pressure. Now patient Now patient is telling, patient is not able to open mouth completely and patient having pain on nearly the TMJ area. So is showing the pain on TMJ area. So that is seen in anterior disc displacement without reduction. So we should be able to differentiate hardened field and softened, very important diagnostic feature. Another feature what we can do is you can apply a tongue blade and you can ask patient to bite. If the muscles, if the culprit, the patient will have a pain on the same side, or if it is a TMJ is the culprit, the pain will be relieved on the same side. Okay. So can you see the patient is biting on the right side, there is a contraction. If there is a pain in the muscles, patient will have a pain. If it is a TMJ pain, obviously it will be getting relief on the site of biting. This is another test which you can do in your chair side. So there are advanced diagnostics also there, like T-scan, jaw tracker, joint vibration analysis and EMGs. That is comes under neuromuscular dentistry, and can read more over that. Now treatment is because it's not very easy to be treated this case, because the systemic evaluation should be done, the exact causes should be known, then only we can treat these cases easily. So elimination of stress is the most important thing, and if there is sleep deprivation, patient should be educated, and the medication should be given for sleep and any other etiological agents. So pharmacotherapies, if we see muscle relaxant, we can go for the centrally acting muscle relaxant, but as per my experience, these muscle relaxants are having a very questionable role rather than the anti-anxiety drugs and the physiotherapies. Moist heat application can be done to relieve to causes vasodilatations and the stimulation of A beta fibers, and that is specifically causes gate control relief of pain. Spray and stretch, that is a good technique where we can use a cold spray, and I advise patient to stretch his or her muscles as much he can, so there don't be any pain. So this technique a very successful technique to relieve muscles pain. Trigger point injection, which I usually follow in daily routine, and you have to palpate trigger point first and then inject either lignocaine or the dextrose, 12.5% dextrose, that is called as prolotherapies. That will also relieve pain. Okay, this is how we does trigger point injection. First palpate properly, because the successful aspect of trigger point injection is to check properly about the trigger points. If you miss the trigger points, you will inject local anesthesia in some other places. So make sure that you are injecting onto the trigger points. Once you inject it, you have to check for local twitch response. If you are in a correct place, patient will jump. That is a sign that you are injecting in a correct place. See, this is the local twitch response. It can be ultrasound guided also, but the trigger points is very small in the muscles of mastication. If it is the muscles of back, then ultrasound guided is good. So what we are actually doing with trigger point injection, we are just try to stimulate the trigger points to generate ATP. this is the injections of trigger point injection on masseter muscle, trapezius, CM, splenius. On TENS therapy, that is another physiotherapy, TENS therapy, that is the transcutaneous electrical nerve stimulations. We use low intensity electric current. We all have this TENS therapy in our dental clinics. So what exactly it does? It either causes gate control theory, that is stimulate the A beta fibers, then it also releases endogenous pain control by endorphins, enkephalins. It also increases vascularity, it also have a placebo effect. So the main is it causes A delta A beta fibers, okay, A beta fibers, it stimulates A beta fibers, it closes A delta NC fibers, that causes no sensation. So हम लोगों ने पढ़ा हुआ है final year में, nothing new in that. So stabilization splint is also have been tried in very successfully in case of MPDS, but it should be stabilization splint, it should not be night guard. There is a difference between night guard and stabilization splint. It should be a flat stabilization splint. Slow है थोड़ा सा. Okay, low level therapies or photobiomodulation also can be used, where we use 635 to 980 nanometers to release certain chemical mediators, and we can use 2 to 3 joules around the trigger points, that will relieve the pain, but don't overuse it, again it can cause their own effects. Okay, so this was about the MPDS. Now one more condition is called as fibromyalgia, which usually we get confused the fibromyalgia with MPDS. We just palpate masseter muscle or temporalis muscles and we say that is MPDS. But what we have to do is always try to palpate all possible muscles, not only the orofacial structures, along with the hands and the feet and the back, because there might be a fibromyalgic condition which is very common in old ages, and you will be just doing physiotherapy for a local muscles like masseter or temporalis, but patient will not get relief. And fibromyalgia is very common in older age. So there will be 18 trigger points, there will be 18 pain points which you have to palpate, because there are lots of comorbidities for fibromyalgias, like there can be a migraine, joint hypermobility, anxiety, irritable bowel syndrome, polycystic ovarian disease and hypothyroidism, the case which I have discussed like polycystic ovarian disease. So you have to differentiate fibromyalgia and MPDS because the treatment modality will differ. So they require tricyclic antidepressant, duloxetine, anticonvulsant. It is very difficult to treat, but at least you can diagnose properly and take consultation from your ortho consultant or neuro, and you can also give at least tricyclic antidepressants and all can be given. So my topic was very easy topic, not like which from afternoon I am seeing very great topics of great techniques. But these cases comes in very routinely it comes under your clinical practice, and we misdiagnose these cases. Okay. So correct diagnosis is very important, and details systemic evaluation like sleep history, stress, menstrual irregularities, vitamin D deficiencies, these are very important. Don't misuse muscle relaxant and painkiller. We all in the world where aceclofenac is combined with different type of muscle relaxant, all muscle relaxant is combined with all anticonvulsant, lots of combinations are going on. So don't misuse those drugs. Okay, first proper diagnose it and then you give. Ruled out odontogenic cause, that is most important. Then fibromyalgia, it also should be differentiated. So keep getting more and more knowledge about the muscular pain, because MPDS is not only the one, there is few more, but because we have only 20 minutes time schedule, so that will be enough for me. Thank you.
Biswas sir. Topic for this session is From Despair to Repair, Saving Endodontic Cases Against Old Odds. Over to you, sir.
Hello. A very good evening. I'm very thankful to have this podium and given by 12th World Dental Science Annual Conference and Cynodent. As it's been a long day and so much of plethora of knowledge has been imparted, so I'll be very short. My topic of presentation is From Despair to Repair, that is to save all the endodontic cases. But with the invent of implants, as we know, every tooth which has been extracted, or we have a fair chance to put implants. But initially when implants were in use, and if the patient cannot afford implants, what best we can do? Supposedly if a tooth has been out for around 1 hour or maybe 18 hours, and if the patient presents that teeth with you, that can you do any justice with that tooth? So series of cases which I will be discussing of those endodontic cases, or maybe the reimplantation, intentional or delayed, how we can treat them. So this is where the institution where I work. I am faculty, currently assistant professor in All India Institute, Guwahati. So the cases like this, where the fracture of the file has happened at the apical third, she was a 18-year-old female. Then in cases where the tooth has been brought in a kidney tray and we put it in saline, or a tooth which has been brought in a postcard. So can it be treated or can it be salvaged? So, and this is a routine case where we see pathologic perforation or iatrogenic perforation of tooth. So let's start the journey. First and foremost thing is that don't limit your challenges, in fact challenge your limit. So reimplantation can be defined as reinsertion of tooth back into its socket due to avulsion or trauma or any other iatrogenic procedure. So it depends on many factors. Obviously age, we know that in case of age, if the patient is younger, then the chances of reimplantation is much better as compared to older individual. Then width and length of root canal, the more the width, more is the PDL, so better is the chances. Then comes the mechanical damage. Now if there is a trauma where the buccal plate or the palatal plate has been hampered, so in that cases obviously the chances, the prognosis is lesser. Then sprinting of reimplanted tooth, whenever we are doing sprinting, it shall always be semi-rigid, because we need physiologic movement of the teeth. Then effect of mastication, it has been seen when the patient has mastication effect, a little hard tooth, then the chances of ankylosis is less, and therefore masticatory stimulation is needed. Then external duration time, we have all read in the chapters that the duration time of the tooth should not be more than 1 hour, because the PDL fibers start getting degenerated. So storage media, what are the main characteristics of storage media? These are the main characteristics of storage media, where it shall maintain the periodontal fibers, the osmolarity, no antigen antibody reaction, and so on. So the best of the storage media is HBSS, that is Hank's Balanced Salt Solution. If you don't have, you can use Viaspan. Even chilled milk, the cold milk can be used, or not lesser than saline. So this is again the definition of interest. What is the good candidate and bad candidate? The one which has flared root, obviously we have to intentionally do the reimplantation by removing it, so chances of fracture is more. Such in case, this is a good candidate. So we will come to the first case. So the patient came with a chief complaint of right lower back tooth region past 15 days. So root canal treatment was done, and as a result there is a fracture we can see. Therefore, this is the orthopantogram showing the fractured file, and this is well near the inferior alveolar nerve canal. So after that, what we did is that we carefully removed the teeth. Now the removement of the tooth was done as atraumatic as possible. Why? You can very well appreciate the periodontal fibers. Now this treatment has to be done within 15 to 20 minutes because the degeneration of PDL starts happening and therefore chances of rejection happens. So the separated file was carefully removed from the root apex, and you can see that the periodontal fibers are still intact, and this is the separated file. So after that, the canal was redefined. The root canal treatment was done as we generally do in standard operating procedure. Irrigation was done with 5.25% sodium hypochlorite and EDTA. After that, the canals were obturated with F2 Gattabacha and H+ sealer. So this is how the picture. After that, what we have to do is that coronal the apical resection. So we had done the apical resection, that is 2 mm depth with the ultrasonic, and we fill this with biodentine. We can fill this with biodentine or MTA. Why? Because these are biocompatible materials, and we need to basically eliminate the apical ramification where the maximum load of bacteria is there. Otherwise, then there are chances of bacterial invasion or ankylosis or many other things. So again, the tooth has been placed back to the socket. Now when placing back to the socket, we have to do with slight digital pressure, and then this pink color is basically the splint. Because of the blood and the fluids, it has become pink. Otherwise, this is the splinting which has been done from the premolar to molar. Okay, so this is the immediate post-operative photograph, as we can see, and this is the follow-up after 9 months. So you can very well appreciate the amount of bone loss. The radiolucency has turned into bone. This is after the 9 months of follow-up. So it has been well taken. Then second case is of delayed reimplantation, where the patient came with a tooth. So we immediately placed the tooth in the saline because we have to moist it up. Now in this case, the periodontal ligament is already dead. It's already 18 hours. So in that case, what we have to do is that we don't have to scrap the tooth, because still to remove the PDL, in fact we have to do the chemical treatment, like we can use sodium hypochlorite or EDTA 24% for the surface treatment. After that, I have placed the tooth in tetracycline fibers. Now this tetracycline fibers helps, basically tetracycline has a property of anti-resorptive property. So if we place this, then the resorption of the bone will be less as compared. So these are the tetracycline fibers where the surface treatment of the tooth has been done. Then similarly, whenever we are placing, in case of reimplantation, we have to resect the root to remove the apical ramification and the intricacies. So after that, we are preparing with the ultrasonic, and this is the MTA which has been mixed, mineral trioxide aggregate, and then with the help of MTA carrier, we are placing in the tip of the root. So this is the final outcome. So this MTA, that MTA or biodentine, whichever you are using, has to be depth of 3 mm. So it is again placed back in the tooth. So this was the, the tooth, it is again placed back by slight digital pressure. After that, we have done the splinting. This slight, that thing is the splint. So this is after 2 weeks of post-operative procedure. Then this is the third case. Here also, the patient got the tooth in the postcard as I showed earlier. After that, the tooth was soaked in 2.4%. Now this soaking of the tooth is at most necessary if you are planning for reimplantation. That is 2.4%, 5.5 pH solution for 20 minutes. After that, so this was the patient, how he got the tooth, mode of transport. So we used in this case doxycycline, tetracycline doxycycline. Why? Because there are two types of root resorption. One is external root resorption, one is internal root resorption. So in this case, external root resorption is bound to happen. So in order to reduce that, we are using this kind of surface treatment. So after that, this tooth has been placed and a splinting has been done. So this was the fiber splint, and this is after placed back after the socket. So this is after 3 weeks of the removal of splint. We should generally place the splint for 14 to 21 days, and this is the 3 weeks, and this is the clinical picture of palatal region. So how the gingival tissue, how it has taken, even if after the tooth was out for 1 day. So this is the 5 months follow up, and this is the IOP X-ray after 5 months. So the bone has also taken up the tooth, in fact, and there is no external root resorption. You can very well appreciate. So perforation repair with the MTA, we must be doing endodontic cases. In such kind of cases, we generally come up with perforation. So how to deal with perforation? Basically, we have, after the perforation has happened, we have to negotiate all the canals, and we shall have collagen in pack or cola plug. Now this cola plug has to be placed over the perforation area so that the bleeding can be stopped. After that, we can repair with either the MTA, that is mineral trioxide aggregate, or we can use biodentine. So this is a case of perforation, and we have placed MTA. After that, the root canal treatment has been done, and this is the picture after 1 year of follow up. So this is another case of perforation, same way we have done, but here we have used floor reinforced with GIC. So this is the post-operative image after the 8 months. So the important point in case of perforation repair is the location of furcal perforation. So it should be at the level of epithelial attachment and crestal bone, which suggests a guarded prognosis. Also the sufficient prognosis, perforation matters. Supposedly it is involving the whole the floor of the tooth, then you cannot repair, because eventually after the crown preparation there is chances of vertical fracture. So intra-alveolar transplantation. So in this, why it is done, when the crown root fracture is going subgingivally and has problem like isolation, maintenance of biological tooth, and restoration. So these are basically the classification of the fracture of the tooth. Now in this case, as you can see that the fracture of the tooth has happened at the the CEJ junction at the clavicular margin. So what we did is that we have to remove the tooth carefully outside, and we have to rotate it 180 degree. So we have rotated the tooth 180 degree, and then we have done this splinting. So after this splint, what we have done is the obturation, and this is the custom made post. In BDS time we have to make custom made post, not the fiber post. So we have made a custom made post, and then we have placed the crown. So this is the immediate obturation done, and the fragment reattached. So this is the second case, I suppose. Then this is something which comes to the clinic very rare, radicular groove. So I'll be just taking few minutes to explain what is radicular groove. So palato-radicular groove is an anomalous formation of tooth that begins in central fossa of maxillary incisor, extends over the cingulum, and continue apically to varying depth and distance of the root. So this usually occurs in lateral incisor, more of central incisor, and the incidence of ranges from 0.9 to 9.6%. So with the diagram you can understand that this is the palatal groove which occurs, and this can be shallow or can be deep, and these are the types. So these teeth are generally not associated with caries, and whenever you take an X-ray there will be a periapical radiolucency. Now the thing which can be come in mind is that whether it is because of trauma from occlusion, whether the patient has some traumatic bite, but when you take an X-ray, then with the X-ray you will see a periapical radiolucency, and also you have to see this groove. So this groove is important, and there will be maybe a sinus opening as well in the labial or the buccal side. So what we have to do in such kind of cases, we have to remove the tooth. Well, first we have to do the post-obturation before removing the tooth. After the obturation has been done, we carefully remove the tooth as atraumatically as possible. Why? Because this groove need to be treated. So preparation we do with the ultrasonic, and then after that we see this is the 9-month follow-up. We can use a bioceramic sealer or some kind of thing to seal this area. Like in next case, this is another case. So we have done the tooth extraction, and groove is extending up to the root. So this is the groove, and then we prepare this area with the ultrasonic. After that, sealing is done with iRoot BP+. So this white area, after this material has been set, we again place the tooth back and seal and do the splinting. So this is another case similar which we have done. Here in this case we didn't remove the tooth, in fact we basically did the periapical surgery and we sealed it with iRoot BP+. So this is the suturing, post-operative 18-month follow-up. Then this is mandibular canine with 3 canals. The X-ray was not good because this was I took in some clinic, but you can very well appreciate that there are 3 canals in a canine. So definitely this has to be done under dental operating microscope or maybe a loop. So this is the classification. So this is Gulabi wala classification where 3 canals join into one, and this is the post-obturation which has been done. Then comes the furcal perforation with separated instruments. Now in this case there was a separated instrument as well as furcation. Now what we can best do? First is that with C+ file or any VDW files we have to negotiate and bypass the instrument, and after that we have done the perforation repair. So this is how the bypass of the instrument has been done in this case, and then the perforation repair has been done, and this was after 3 months, very well tolerated by the patient. So this probably will be the last case of mine where there was a fracture of the tooth, and this is the tooth. So we have to prepare this area as well, the crown area and the root area, and then we have placed a fiber post inside after doing the root canal. So this is the fiber post in place, and then after that the tooth has been reattached back to the area. So I would like to say that believe you can, and you are halfway there. Thank you.
Dr. Neelam Das, ma'am. Topic for this session is groundbreaking application of artificial intelligence in periodontal research. Over to you, ma'am.
A very warm good evening. I think आप सभी लोग wait कर रहे हैं because the scientific presentation result. I'm from Kanpur. Myself, Dr. Neelam Das. I am Associate Professor in Kanpur. Today I have chosen this topic, that is artificial intelligence, specifically in periodontal research or any research topic, specifically for the students only, whether the PGs for their academic work, specifically their hard days, that is their library dissertation or dissertation. So let us begin with this. This is my department with my HODs and my all PGs. Till now I have completed more than 100 researches in my field. So I will guide you or tell you the few things how artificial intelligences work in your academic researches. How with the help of various tools you can accelerate your research and you reduce your traditional burden in those hard days. So I think all of you using Alexa in your home, maximum. Now this tools already it is useful. We are using in treatment aspect, but now we are talking about in research, in academic writing, how this tool will help, because in my views there is a generation gap between the artificial intelligence, how it implement in the research. So today this is the topic of my presentation. I will cover in this few contents how talking about the basic knowledge or the constitutes, how artificial intelligence work and how it implement in the academic writing. Begin with the manuscript preparation till the publication in a respective PubMed journal. Okay. So let us begin. We all know that artificial intelligence, it is coined by John McCarthy in 1956. It is not new, but the use of this in research, this is something new in dentistry also. So this artificial intelligence has brought a paradigm shift. It not only refined the methodology, it can also introduce the data handling, analysis and various dissemination. So with this we can prepare, not only prepare the manuscript, we can go to the result part, we interpret, we go to the plagiarism check and we publish in a various respective journals which the students want in their PG academic. Okay? Let us give a basic idea what artificial intelligence has. You all I think know about it, or let me introduce. Artificial intelligence has a few steps like machine learning, natural learning, processing, they are the types. In machine learning, actually it is a type of artificial intelligence, but it retrieve from a large database. Then it implement to a research. It has a sub part, that is a deep learning, which include the neural networks like artificial neural network, convolutional neural networks. The next, natural languaging process. It is a machine, so that this machine can communicate and implement in human languages. Next, expert systems, visions, speech, plan and robotics. Robotics, that is a AI in a physical form. This all constitutes in artificial intelligence. Next, how this artificial intelligence actually work. This diagram will tell you how it works. The difference between the human brain and artificial intelligence is one thing, that is it has a layer of neurons. Like first step, there is a shallow neuron input and output, in middle there is a hidden. While talking about the deep neural network, it has a layer of hidden neurons. What it can work, it can retrieve a knowledge of input layers and it communicate to the output layer. Why we call a hidden? Because it has a multiple layers. What this does, this hidden layers will implement all the knowledge from the input and it will give to the output layer. Next, the convolutional neural networks. It has a scan where it visualizes digital outputs like all the digital like images, videos, this will analyze. This is the basic difference between the human brain and AI. We all have the neurons also, but the main part, it has a, it embedded with a neurons, it embedded with a deep layers, so it can enable the multiple layers of input and output layers. Now the topic begins, how this AI work in research, how we can use this various AI tools in the research purpose. By this presentation, I will tell you the schematic diagram. For the research, we all in conventional times, in previous times, we are doing the research works. So this research works is done by the human brain, which has a cognitive knowledge or skill. But by the implement of this artificial intelligence, the various tool, it's analytic or resource tool, it will help or it will reduce our burden and time. Okay. This graphical representation, it is a layout where it tells this artificial intelligence how it work in research or a theory development. Theory development, it is a part of academic research where this theory, this implement with the knowledge in the field of respective study. Study in the respective every field, every 9 departments of dentistry. So what are the four, it has to cross the 4 phases. The first phase, we have to cross check all the information. In second phase, we have to rationalize our information. In third, we have to evaluate the outcome generated by the artificial intelligence. And the last, we have to combine the research input, that is the cognitive knowledge, and the artificial intelligence result. So by this combination, we can lead to a research work or a theory development. Now begins, what are the tools which are useful for the topic selection? Yes, as a student, for a research purpose, for a thesis, we have to need what are the tools which helps. These are the few tools like, RCF Sanity, Schematic Scholar, Scopus and ResearchGate. These are the various AI tools which help to identify the research topics. and it will gather the information also, because it utilizes the advanced algorithm to gather the extensive part of a research, that is a literature review. Next AI tool, that is for sampling method. We all need the inclusion and exclusion criteria of the sample. These are the few tools which helps. What are the tools? That is G-Power, RedCap, Qualtrics, SurveyMonkey, OpenAPI and AI algorithm. These are the various tools which help to our methodology. Next we talk about the literature review, the tools which help to gather the information for our research. The tools are RSAI, EndNote, Mendeley, Zotero, PubMed AI. Mendeley, Zotero and AI, they are the new tools. This is, we can install it. We can install in our desktop, we can add in our word processor, and it will automatically give the references to our manuscript. I will give an example where I integrate all this AI tool in a respective topic. Next, for the data analysis or the result part, that is SPSS modeler, Tableau, Python and SAS, that is statistical analysis systems. This perform the advanced statistical test. It is mostly used by the statistician. So by researcher, we have to be have some knowledge about these tools, so we can interpret our result also. Next, what are the tools which is used for comparative analysis, for the comprehensive review and the meta-analysis research? The tools are RevMen, Covidence, Rayon, API Review and Distiller SR. These tools, they enhance the efficiency of the systemic review and the meta-analysis. Next, they not only enhance, they facilitate the robust conclusion in any research. Here as a periodontitis, I am working on a periodontal research. So, this give a better result to our periodontal research. Next, very important part, that is originality and integrity. We all facing the plagiarism in any manuscript, whether the dissertation, whether the LD. So these are the few tools I think most of the students are using. These are using by the institution also, that is iAuthenticate, Turnitin, Unicheck, Grammarly Premium and PlaqueScan. Next, what are the AI tools which is used for the writing, academic writing tools? What these tools are? Grammarly, Writeful, Pro Writing Aid, Skyflu and Typeset. These are the few AI tools which can install in our desktop, which can we can use this AI tools for best academic writing. That is all the academic purposes. Next, I will go to, by discussing all, I have given an idea and I have proven how this AI tools work in a research. Now, next I am going to integrate how this various tool works in a respective topic. See, I integrate these tools in one topic, that is local drug delivery in periodontitis. Okay. These are the tools which I discussed. These are the tools which is used for the academic research purpose. The topic is local drug delivery. What we have to do, the respective tools. First, we have to find what are the topic, then enter the keywords, then install and review. The first is Discover. While talking about the RCF, we have to go to the website. We have to give the keywords and then update our research. Next, Schematic Scholar, same, go to the website and search for our respective topic, that is local drug delivery in periodontitis. Then we have to use the special features what he has, that is explore, citation and the references. Same thing for the Scopus and G-Power. Scopus also for the, go to the website and use the terms periodontitis and local drug delivery system and go to the result part. G-Power for the result analysis, RedCap, Qualtrics, SurveyMonkey and API, this all for the academic writing. We all go to this and we all make the research in an extended view. Next, Mendeley, EndNote, Zotero, They all, this tools for the, specifically for the research, we can install it, we can make our manuscript writing, all the citation or the references are come one by one. Covidence, Distiller SR, Rayon, API Reviewer and Grammarly, this is all for the, specifically for the manuscript preparation, making it grammatically, making it correct way. So this all give a style for our manuscript according to the journal, which journal we want. And at the end, this all tools for the plagiarism checker. So what, at the end, I have searched some links for all of you. This various AI tool which is helpful for a research purpose. So that I conclude that this various AI tool, it not only help, it will make a streamline beginning with the publications to the manuscript writing till the publication in a respective permit journal. Rest, it can also has the ability to process extensive data, literature review, and it accelerate the innovation and clinical advancement in our academic research. So we all have to use these AI tools to reduce our traditional conventional research writing. So it will reduce our burden also. Thank you all.
For the last lecture of today, I would like to invite Dr. Bhuvan Nagpal sir. Topic of this session is essential traits for excelling in oral pathology. Over to you, sir.
Check. Good evening, one and all. Am I audible at the back? How many are students here? Please raise your hands. Okay, that's really great. And how many are practitioners or faculty? Okay, fine. Anyways, my prime agenda was to target students only, because mine is the last presentation and I won't take much of your time. Only thing is, I want to highlight some of the peculiar things about the domain of oral pathology. This is my business card, and I am the India's first NABL accredited and approved authorized signatory for lab reports, which includes all the investigations except histopathology and cytopathology, which are belonging to head and neck region. My lab is Tohana Mangalam Diagnostics. It's the first and only diagnostic center with registration with Clinical Establishment Act in my city, and only NABL accredited medical lab in Tohana. And I am the primary NABL approved authorized signatory for lab reports. This is my team. You can Google my name on, you can Google my name and you can get information pertaining to my. Then I have one more center, which is for the Center for Oral Pathology and Maxillofacial Diagnostics, that is COPMD, for the diagnosis of OPMDs. You know what OPMDs are? Oral potentially malignant disorders. Recently, last year, I have founded one association which is registered in Haryana, and it is working to promote the specialty practice of oral pathology and to empower oral pathologists in India. I have one more academy, that is AOPLM, Academy of Oral Pathology and Lab Medicine, which is ISO certified, and under that courses for oral pathologists who want to learn more aspects which are not taught as per the curriculum in colleges. So just to highlight that man is not immortal but remains immortal through his work. Is it true or not? So my presentation is dedicated to Dr. Anita Borges, and those who do not know Dr. Anita Borges ma'am, You can Google, and she is the last word in histopathology. कभी किसी को histopathology के diagnosis में doubt हो, तो you can go to Mumbai and show the slide to her. Whatever she says, that is the last word. She has that Midas touch, and she has experience of more than 50 years. Even a road is named by his father in Mumbai. So she is my true mentor. And next is, I am very much mesmerized by Dr. William G. Schaefer's, the textbook which you people must be reading in undergrad. So I just want to declare that this presentation is an informal effort to highlight and to think about the knowingly unknown qualities of oral pathologists with a different perspective, and it will be blend of my own comprehension and experience in medical diagnostic industry for more than a decade. And I just want to say that take these aspects in a positive sense. Every branch has its own pros and cons, and I am just here to highlight the importance of oral pathology and what all traits are required to become a good oral pathologist. So start करते हैं oral pathologist की कहानी उसी की जुबानी. So what oral pathologists do, why they do, where they do, how they do, and when they do. I have a question to majority of the audience here. I know some may be hating the subject. So do we dash oral pathology? You just keep the answer with yourself. I will ask at the end of the presentation. I just want to say that the value of college education is not the learning of many facts, but the training of the mind to think. This is what Dr. Albert Einstein has said. So I just want to ask 3 questions. Had pathology or oral pathology not been there, what would have been the story of medicine or dentistry? अगर caries होएगी ही नहीं, cancer होएगा ही नहीं, या और कोई भी pathology नहीं होगी, तो what will happen? I know these are hypothetical questions, but give a thought to them. Do we really value the plethora of information about oral pathology? Imagine if all the information regarding oral pathology is lost, what would be the situation? Now you never know what you have until you lose it. आपको कभी भी उस चीज की वैल्यू नहीं होती जब वो आपके पास है. Be it a phone, be it any material, be it any relationship, it is a true fact. So see, this is the graph. You can see that the value of something when you do not have that. And when you have this, the value reduces. And when you lose that, suddenly the value increases. So what is pathology? Pathos is all about diseases. It means the study of diseases, and it is a specialty of medicine and dentistry. Oral pathology is nothing but a confluence of basic sciences and clinical dentistry. And as per our curriculum of MDS DCI regulations 2007 and 17, which says that a dental surgeon has to be trained in general and special pathology, and to carry out all the investigations which are being done on a routine basis in any of the diagnostic center. So if we see the definition, so the specialized field of pathology dealing with the diseases of oral cavity and its associated structures, teeth, tongue, bony tissue, maxilla mandible, joint, lymph nodes, nerves, blood vessels, nose and throat, and structures in the neck. So according to Dyke, a physician using somewhat different methods of observation, a microscope rather than a stethoscope, the results of chemical and bacteriological investigations rather than the unaided senses. McLendon has aptly described pathologist as a physician, as a scientist, as an educator, and a leader. So in my opinion, oral pathologists are microscopic or tissue physicians, laboratory physicians, disease detectives, or doctor's doctor. If any other best name you know, you can suggest me later. So how they work? Our work is like movie directors. Because by diagnosis, by doing a correct diagnosis, the treatment plan will be better and then the prognosis will be good. So the work of oral pathologist is like Sherlock Holmes. So you have to diagnose that disease or to find out what is the correct diagnosis at the tissue level, including many aspects, which includes history taking, which includes different techniques of investigations and many other traits. So to solve the mystery of disease or slide, oral pathologist uses 7 qualities. Number 1, what are these? Whose eyes? Please wake up, please wake up, only 10 minutes. Whose eyes? Very good. So the beauty of the eyes is not how they look like, but how they see. This is by me only. Whose eyes are these? No, it's not the eyes of Donald Trump. These are the eyes of Dr. Brad W. Neville. The Neville textbook you must have read. So he's an oral pathologist. So eyes are the mirror of soul. So you can see the hematoxylin eyes. There was a song, no? Blue eyes. Yes. So from there only I have taken. So eyes are the mirror by which the information in the slide is reflected to an oral pathologist. They are the sensory organs of vision, but for us, they are the organs of observation. So as Dr. Bill Bass says from US, that you have to be very, very good observer, and you have to be an observer of minutiae and to look at the little things and which make a difference. And that's where our academic training comes into the picture. You have to be born with a certain visual aptitude. So what happens in our Indian system, at the UG level, it is not told what is exactly oral pathology is about. It is not reading just a Schaeffer's or Neville textbook. It is much, much beyond that. So some people, they join pathology not really knowing what it is all about. So what comes next? तुम मुझे brain दो, मैं तुमको. So brain is the higher center, which is central investigation agency, which helps in the thinking process, processing of the information, connecting all the clues to come to final conclusion or diagnosis, then reason and judgment, and visual memory. So now coming to reason and judgment, I'll take 5 minutes to explain that. You know that killing is a crime. Do you agree? Madam, at the last, yes, killing someone is a crime. Do you agree? Okay, then tell me, a soldier, an Indian soldier kills a Pakistani soldier in the war, will that be a crime? Why? Because the context is different. A Jallad hangs a person, will he be punished for killing that person? Okay. If you kill someone in self-defense, then you will be punished or not? Because you have to see the context. And remember, the undergrad students or even the clinicians, in all the cases, you have to see the context. So those who are in 3rd year reading medicine and surgery, I just want to highlight, see, this is the case, a 50-year-old female lady who has osteoarthritis, recently lost her husband, and she is diagnosed mild hypertensive, that is 140 by 90 millimeter of mercury. She lives in Mumbai in a chawl. I hope you remember what is a chawl. There is a Mumbai guy also here. You know what is a chawl? It's a long building with where many people stay together, only single rooms or 2 rooms set is there. And she has to use an Indian style toilet at ground level, ground floor. Now our textbook says, the book says that diuretics should be used to treat mild hypertension. But can you suggest that diuretics can be used for this particular case? What are diuretics? Anybody in the students? Diuretics. These are those antihypertensive drugs which make you urinate, and by that they decrease your blood pressure levels. So in such case, an old lady of 50s, she has osteoarthritis and she has to go and pee on the ground floor. She lives in a chawl and recently lost her husband. So the judgment says, pertaining to this case, no diuretics but anxiolytics, because she is under stress. So this is, I wanted to make you understand reason and judgment. Now pathologists, they are more interested in the recognition of structural alterations but also their significance, understanding of disease, and therefore a foundation of sound clinical medicine or dentistry. This is the brain of Dr. Albert Einstein. Has anybody thought why he was so brainy? His IQ was because that parietal operculum was missing in his brain, which allowed the other part of the brain to grow more than the normal. So as Dr. John Rosai, he is one of my favorite pathologists, and he was from US, and last year only he passed away. He says that visual memory is very important in this field. And there is no question that a person, some people have a better eye than others. Like females, they remember that which color suit the other girl has worn in that party or not. Is it true or no? You remember, no? So it means the eyes are better in females. So and third year resident with a good eye will see something which even an experienced pathologist must not have seen that. Again, I have not eaten enough of the tree of knowledge, though in my profession I am obligated to feed on it regularly, which means that you have to keep yourself updated and keep on reading and gain information from the textbooks and the journals. Now from where this information comes? The various textbooks, the various journals. Then information and experience is different, and information and knowledge are entirely different entities. Information is not knowledge. The only source of knowledge is experience, or what you can say, knowledge is wisdom. You need experience to gain wisdom. Most good judgment comes from experience, and most experience comes from bad judgment. We have seen that a majority of lectures today, people were talking about the mistakes which you should not do, and that was a very good part. So they were sharing their experiences. Now what is the stethoscope of an oral pathologist? Yeah, please say it loudly, no? You never know, maybe tomorrow you will become an oral pathologist and I'll be sitting there, so I'll reply to your answers. So a stethoscope is of an oral pathologist is a microscope. There are different types of microscopes. Now what is this? Anybody wants to read this? सांसों की जरूरत है जैसे, सांसों की जरूरत है जैसे जिंदगी के लिए बस एक सनम चाहिए आशिकी के लिए. Here I am not going to give any sanam or ashiki. I just want to say that diagnosis की जरूरत है जैसे, diagnosis की जरूरत है जैसे treatment के लिए बस एक बायोप्सी चाहिए हिस्टोपैथ रिपोर्ट के लिए. So here I want to emphasize that all students or all general practitioners who can identify any white or red lesion, please don't believe on their eyes what they are seeing and don't defer the patient. आप ये ले लीजिए एक महीने के बाद आइए. No, you should always do a diagnostic biopsy and send it to a histopathologist. दिल चीज क्या है आप मेरी जान लीजिए, बस एक बार मेरा कहा मान लीजिए. हिस्टोपैथ रिपोर्ट चीज क्या है, आप IHC की रिपोर्ट लीजिए, बस एक बार बायोप्सी करवा लीजिए. For us, biopsy specimen is equivalent to patient, a blood sample is equivalent to patient. So the different vitals in oral pathology are cell morphology, basement membrane and inflammation. This was the reason why I didn't took any other topic to explain, because again histopathology, it will become a very boring lecture and everything will go above the head and later everybody will clap and just go away. So these are the signs and symptoms. We can only see the signs. The cells cannot tell us the symptoms. So necrosis, apoptosis, different histopathologic bodies, cells, patterns, inflammatory cells and dysplasia. This is very important because on the basis of dysplasia we grade as a sarcoma or a carcinoma. I guess you people are aware what is a carcinoma and what is a sarcoma. What is oral pathologist temple? That is our laboratory. So analogous to physical examination in medicine, surgical procedures in surgery, tooth preparation and RCT in cons and endo, bracket placement in orthodontics, in oral pathology we have histopathological examination or microscopic examination. So these are the basic processes which happens in the body. I have categorized from my experience, either it will be an inflammatory lesion, it will be a developmental lesion or hemodynamic or immune mediated or a neoplastic. Majority of the lesions are either inflammatory, immune mediated or neoplastic. Now coming to words. Words can be powerful when put into action, they become life changing. So again, pathologist Dr. Paolo Domizio says that you have to picture, when you read a report, you should be able to picture what the pathologist who has written that report is seeing. You have to have a skill in putting up what you are seeing down the microscope into the words. So what is a histopathology report? This is it is a blend of good slide observation along with thorough thinking, with proper reasoning and judgment, which is put in together into the beauty of words. Every slide is a mystery. Pathologist solves it by history. To solve the mystery of disease or a slide, we need observational skills, a visual memory and thinking skills to join all the clues. We need knowledge which will come through books, journals and experience, a good microscope, specimen, either blood, biopsy from the patient, a good laboratory and then a written report. Now again I ask you the same question, do we dash oral pathology? The options are live, like, love, passionate about, all of the above, none of the above, any better option which you can tell. So the dictionary meaning of like is to find something pleasant or attractive, to feel about, inclination or preference, love, a strong feeling of affection, passion, an intense desire or enthusiasm for something, anything which arouses great enthusiasm compelled by intense emotions. So allow your passion to become your purpose and it will one day become your profession. So this is true for any branch, not only oral pathology. If you are passionate about any branch in dentistry, please pursue that. Thank you so much. And lastly, I would like to acknowledge the organizers, Dr. Ashish Chandra sir and Dr. Anmol Bagaria ma'am, for giving me the opportunity to present my point of view or my presentation in front of you all. And one small thing I wanted to tell, that last year in the month of March, there was a judgment passed by Madras High Court. As I am also a lawyer, there was a huge discussion between a lawyer today. So, क्या आप लोगों को पता है लॉयर क्या होता है, एडवोकेट क्या होता है और बैरिस्टर क्या होता है? गूगल पे सर्च कर लेना, बाकी मैं बता देता हूँ. Lawyer is the one who has only LLB degree. Advocate is one who has LLB degree and enrolled into Bar Council of India. I have 2 degrees, but I am not enrolled with Bar Council, but I am a medical legal consultant and expert in that. And last is barrister, who the person who has gained LLB degree from England is a barrister. So last year this judgment came which clearly says that BDS is a system of dentistry, is a system of medicine dealing with dentistry. Why this happened? Because there was a case in Chennai, post for food safety officer was announced, and in that many BDS people have applied, but their applications were rejected. So they filed a writ petition, and this was the judgment which was given by the bench of Madras High Court on 23rd March 2023. Thank you so much. So I just wanted to highlight this thing. I think I've finished on time.
Thank you so much, sir. It was a wonderful session. Now, as we have done with all the lectures, and it's a time for the results of your presentations. I know you are waiting for so long. So you all did wonderful presentation, and I know you all did a lot of hard work, and you know hard work will also pay off. So results for the offline paper presentation slot 1R. I would like to invite result for the offline paper presentation slot 1. Third prize goes to Dr. Agrima Sood. Second, one more third prize goes to Bhavya Joshi. Second prize goes to Shushantika Dagar. Many congratulations. And we have 3 winners. First one is Mahir Verma, Shriya Srivastav and Mansha Sajad. We have 3 first prizes: Mahir Verma, Shriya Srivastav and Mansha Sajad. For slot 2, third prize goes to Vastav. For slot 2, we have 2 third prize winners, Vartika Srivastav and Dr. Rishabh Kapoor. Second prize goes to Dr. Tarun Prakash. first prize goes to Dr. Reshu Singh. For slot 3, second prize goes to Dr. Pragyan Paliwal and Dr. Ankur Bhardwaj. I would like to invite Dr. Piyush Shivhare sir on the stage. Dr. Pragya Paliwal, second position. And also Dr. Ankur Bhardwaj. Dr. Mohit Tomar, Dr. Yashika Bali, and Dr. Satnam Singh Joli. We have one more first prize, Dr. Vinisha Bajaj. For slot 6, third prize goes to Dr. Prize goes to Dr. Gaurav Jain. And the first prize goes to Dr. Khushbu Arif. Second prize goes to Gaurav Jain and Priti Shukla. For on spot registration, third prize goes to Dr. Swadnata Raz. Third prize goes to Swadhinta Raz and Supriya. Second prize goes to Bhavya Joshi. And also Divya Rastogi and Love Verma. It's a time for offline poster presentation. For slot 1, third prize goes to Dr. Abhishek Singla, Dr. Jagriti Bora, Dr. Naman Kumar and Dr. Akash. Second prize goes to Devansh Dev and Upasna Patel. Also Manvi Goyal, and Rupa Swain. First prize goes to Siddhant Sharma and Farhad Sandhu. For slot 2, third prize goes to Priya Dhama, Anusha Rana, Antara Shukla, Shreya Saxena, second prize goes to Yatharth Pannu, Yasleen Kaur and Agamjot Singh, and also Diksha Sharma. First prize goes to Arjit Chandra. For slot 3, we have only first prizes in slot 3. First prize goes to Dr. Fatima Rashid Khan, Dr. Fatima Rashid Khan and Dr. Saif Rauf Siddiqui. And also Dr. Brijendra. For slot 3, second prize goes to Khushi. For table clinic, first position goes to Dr. Rishi Singh, Dr. Prashantra, Dr. Reshu Singh, Dr. Prasanta, Dr. Suchetana. Second prize goes to Dr. Shweta, Dr. Alankrita and Dr. Surbhi Singh. Divya Mishra and Rama Pandey. For on-sport presentations, second prize goes to Dr. Prashant Dwivedi, first prize goes to Dr. Vijay Shri Pandey, in UG category. Third prize goes to Pavitra Rastogi and Love Verma. Ayushi Jaiswal, Nishu Kumari, Ayushi Jaiswal, Nishu Kumari, Tanjot Kaur, second prize goes to Pragya Gupta, Rosal, Tanishka also holds the third position. First prize goes to Shivam Pathak and Nandini. And Monica Sharma. First prize goes to Shivani Pathak and Nandini. And Monia Sharma. So we are done with the prize distribution. Congratulations to all the winners. Organizing committee. Got a first prize in dance.
In TV.
and welcome back to this U.S. Open Office Plan.
Miller just lobbed a message way over Jones's head using some
Next we have Shubhangi.
We have for Dr. Piyush Shivare sir in the category of Oral Medicine and Radiologist of the Year.
Next from the organizer.